this 2022 World Tour organized by Ifhnos. It's really a pleasure to have everybody here today. And we are ready to have an incredibly rich program. And before that, I'd like to share my screen and perhaps share with you a few words about Ifhnos, who is sponsoring and organizing this world tour. So you may or may not know that the organization of the International Federation of Head and Neck Oncologic Society was born 35 years ago in 1987, when 11 leaders from around the world, under the vision and the formidable leadership of Dr. Jatin Shah, looking at organizing and putting together the NIDAS, which will become the largest global organization dealing with head and neck oncology worldwide. From that initial meeting, and after establishing this collaboration, Ifhnos has thrived and continued to grow and has created a global major impact on head and neck cancer awareness, early diagnosis, and appropriate treatment for patients. However, the major impact and the continued focus of Ifhnos is to promote education, teaching, and training for physicians and surgeons involved in the care of patients with head and neck cancer anywhere in the world. On this slide here, today you can see the 65 National Head and Neck Society. This is a conglomerate of the largest societies across the globe coming together for the sole purpose of promoting the goals and objectives of Ifhnos. On this slide, you can see 58 member nations with the flag of every nation represented. And here on this map, you can see how Ifhnos is spanning the entire globe. There are many activities for Ifhnos, and time will not allow to detail all of them, but I'd like to give you a global perspective of what these activities look like. So Ifhnos organizes world congresses, world tours, Masters of Head and Neck Surgery educational programs on technical issues in surgery, instituting international collaborative databases. And one of them is currently looking at sinonasal cancer across the globe to update the initial collaborative international study on skull-based surgery, promotion of World Head and Neck Cancer Day, Global Online Fellowship, or GOLF as we know it, observership that is granted by specific institutions, and of course, online educational resources. So the World Congresses, you can see some of the previous locations, and they have been very successful in galvanizing people from all over the world to come and share their knowledge and expertise in a collegial atmosphere that promotes our specialty for the benefits of our patients. The next World Congress would be in 2026 in Brisbane. Global Online Fellowship, or GOLF, is dedicated to providing both online coupled with observership programs to prepare the future generation of head and neck surgery, head and neck surgeons all over the world. This is a comprehensive international fellowship. And as you can see, the two components here, the online education and training and the one-on-one observership, in pre-selected and approved international destinations that will provide the applicant or the prospective fellow the proper training. Master classes on operative techniques that span the entire specialty are archived and cataloged, where you can learn about the technical aspects of surgery from experts representing different parts of the world, different subspecialties within head and neck, and different emphasis on various procedures. The world tour, and you can see here that has been very successful starting 2010, 12, 14, 16, 17, and then COVID hit. But that didn't slow Ifhnos. And in 2021, we had the first virtual of these world tours. And 2021 world tour was extremely well received and led to today. And here's the 2021, and it had 4 days divided into 2 parts of the world. And because of that, the 7th World Congress, because of COVID, the 7th World Congress was moved to the spring of 2023. That brings us to today. And I am so glad to share with you that the World Tour for 2022 has been organized into 2 components. One covers the Western Hemisphere, and that's today. One covers the Eastern Hemisphere, and that's November 12th. So for today, it is my extreme pleasure to introduce and open the day with my co-program leader, Dr. René Lemmens from the Netherlands. And we have a slate of outstanding faculty divided into 2 sessions. And the first session will be led by my dear friend and colleague, Dr. Brian McIver, whom I will share unshare my screen with and let him introduce your first session with an emphasis on thyroid cancer. I hope you enjoy this meeting, and I hope that you put questions and answers in the QA box. The formats are not going to just be keynote lectures, but there will be interactive roundtables, and we would like very much for you to be part of the discussion. So have a great day and enjoy the meeting. Dr. Brian McIver, please take it from here.
Yeah, thank you so much for that kind introduction. I like the picture you used of me there, which demonstrates more hair on top and less hair underneath than is currently the case. So thank you for that kindness. I'm pleased to introduce Dr. Robbie Woods, a fellow in head and neck surgery at the Memorial Sloan Kettering Cancer Center in New York, as my co-moderator today. And he and I will be presenting some cases to our illustrious panel after the keynote. But the keynote speaker today is Dr. Ian Nixon. Ian is a surgeon who hails from my hometown of Edinburgh, Scotland. I've known Dr. Nixon for a long period of time, for many years. In fact, I knew his family even better because his father was a mentor of mine when I was a medical student so many years ago. So Ian, thank you very much for being willing to talk about what's new in thyroid cancer. Let me turn it over to you now.
Okay, thanks for that, Dr. McIver. Just to continue the kind of Celtic subsection of Ifhnos here, isn't it? So let me share my screen, and hopefully you're getting some form of view there. Yeah. So thanks for the invitation, of course. It's an honor to be here, and I've been asked to speak today on what's new in thyroid cancers. As Dr. McIver said, I'm an ear, nose and throat surgeon in Edinburgh, in what they call the NHS in the UK and in the University of Edinburgh. And it's a fairly broad topic, what's new in thyroid cancer. So I'm going to talk a little bit of some things which have changed, the concept of risk stratification and what's new in that field. And then I want to use that as a kind of construct for the rest of the talk. We start with some advances in treatment or over-treatment of the lowest risk thyroid cancers, talk about what probably are the most common patients that people tuning in will encounter, which are kind of low to intermediate risk, where I think in some respects has been the biggest change in approach over the last few years, and then finish off with some examples of the highest risk patients and treatment changes we're seeing in that field. So you can't really be involved in thyroid cancer management without some understanding of risk stratification, and the initial risk systems were designed to predict survival. They were largely based on the size of the tumor, extrathyroid extension, distal metastasis, and critically the age of the patient. Now, there were quite a few different systems promoted over the 70s and 80s, and they've been distilled down one way or another into a kind of AJCC staging. And that's undergone 8 different iterations now, and you're probably using the 8th. And there have been some changes to the way that survival is predicted. One of the big changes was the age stratification. Classically, age as a predictor of survival has been stratified around 45. And that was largely because the average age of populations presenting with thyroid cancer tend to be around 45. But a collaborative effort from many of the senior speakers today, he actually was able to demonstrate that was probably too low a cutoff, and 55 is a more appropriate cutoff, whilst accepting that probably a single cutoff isn't the ideal. But if you see the AJCC staging now, you'll see that the cutoff is at 55 rather than 45. Now, there have been some other changes. T-stage, for example, is the tumor staging. You used to be upstaged to T3 if your pathologist found micro extension, and this is microscopic extrathyroid extension, which is quite a controversial subject in itself because of the incomplete capsule of the thyroid. But one of the big changes was that was no longer deemed to increase the risk of death. And so extrathyroid extension now does not upstage patients to T3. Another nuance of it is that it used to be stage patients over 45 with T1 up to 2 centimeters were stage 1, up to 4 centimeters was stage 2. But there's really no difference in survival because the survival is so good in that. And stage 1 now encompasses both of these T stages. Another change was the end stage. So rather than upstaging to 2, then 3, now upstages you to 2. And what this means is that previously the Kaplan-Meier plots were really overlapping other than stage 4, but now there's a much more broader distribution of outcomes between stage 1 and 3, particularly with stage 4 being limited to very advanced disease. However, the problem with this is that if you predict survival by saying to every patient you meet that they will survive, you'll be right in about 95% of the time, unless you have a very unusual surgical practice where you're seeing the most advanced disease. And one of the problems with this staging system, and the reason it's dry and nobody really could quote much of this to you, they have to refer back to it, is that it doesn't join very well with the approach to treatment. What I mean by that is that you could be any T stage, any N stage, and any at M0. So you have wide nodal metastasis, and you would be stage 1. Yet we would all treat that aggressively in a young patient with radioactive iodine. Whereas you can have relatively limited disease, but be older and fall into a higher stage category and be treated with lobectomy only. And that disconnect between staging and survival risk prediction, and that's the key here, survival risk prediction, has limited the usefulness of this. And what's changed in the last few years is the improvements in ability to predict recurrence. And recurrence is much more relevant for patients because the vast majority are not going to die of disease. Now, this was introduced in the 2009 American Thyroid Association guidelines, but further refined in the 2015 guidelines. And it gives us a concept of what the meanings of low, intermediate, and high risk in a clinical setting. And I want to kind of use this structure to start talking about different parts of this arrow and thinking about how management has changed. I want to not just focus on literature. I want to provide some examples and think about how you might incorporate the changes that have happened over the last few years into your practice personally. So if we start with the lowest risk cases, and these are papillary microcarcinomas, that means they're sub-centimeter papillary cancers. They're extremely common. And in fact, if you look at autopsy series, up to a third of patients are described as dying with thyroid cancer in their thyroid at the point of autopsy, although it's probably more like a 10% risk. And so up to 10% of them are walking around with these in the thyroid. And as a result, if you screen for them, if you go looking for them, either with dedicated screening, as it has been done, or you simply increase the amount of medical screening you subject your population to, which is happening the world over, then you start to find them and you start to diagnose tumors that otherwise wouldn't have presented. And that's the concept of overdiagnosis. And once you've diagnosed them, you have to treat them. So overdiagnosis leads to overtreatment. So one of the things that's new in this field is the concept of treatment being active surveillance. Now, it's likely that many people don't engage in this. It's not taken off in the UK yet. But the Japanese group, Miyauchi at the Kuma Hospital in Japan, have been able to show they've been doing this for many years. And what they do is they take a patient with papillary cancer, they diagnose it on needle biopsy, and the sub-centimeter tumors are offered follow-up with ultrasound rather than surgery. And it's interesting to look at what happens to these patients. Most of us won't have any experience of this. But at 5 years, if you take how many have enlarged, and you can see that in young patients are almost 10%, but in older patients, only 4% have actually increased in size at 5 years, and it doesn't really change at 10. So 96% of these patients remain stable, suggesting where any surgery for them is potentially overtreatment. And almost none of these older patients go on to develop nodal metastasis, although that's more common in the younger age group. And they've been able to show very nicely that this is a safe way of managing patients with the lowest risk disease. Now, it's not only the Japanese groups who have done this. Here, this is another thing I thought was quite an interesting slide, is what could you tell a patient, what is likely to happen to their tumor? And these are two very similar plots, but taken from a US and a Japanese cohort. And you can see that the vast majority of tumors that are subjected to active surveillance, this is the change in volume during observation. And you can see the vast majority really don't change very much at all. Interestingly, a small group decrease in size, and that's seen in both populations, in fact. But anyway, a small group decrease in size and a small group increase in size, with a very small group rapidly increasing. And we're only talking about over 3 millimeters, so rapid is all relative. But you can see that the vast majority of patients actually either decrease in size or remain stable. And so there's only the small group of patients go on to need treatment. So if you're thinking of doing this, and this is taken from the Japanese experience, because they do have almost quarter of a century experience doing this, and you look at what happens to your population that you put on active surveillance, you can see that you, of course, 100% start on active surveillance, and patients fall off for a number of reasons. Some are for these clinical reasons, like increase in size and development of nodal disease. A few are from patient preference, and I think that probably comes down to the way you counsel. And then a significant number get lost to follow-up. I'm sure everyone's familiar with that kind of thing, particularly in these low-risk disease. But the vast majority remain on surveillance and comply with that follow-up and do not require surgery. And this is at 10 years, you're still talking about 70% of patients still being on follow-up. And so it would appear then that active surveillance shows us that with papillary microcarcinomas, tumors generally grow slowly, particularly so in older patients. That it would appear, maybe the Japanese and American experiences are unusual, but certainly their experience is that patients do adhere to the surveillance protocols and that survival is not compromised. And I don't think there's ever been a patient who was subjected to active surveillance who went on to die. Although maybe we shouldn't be surprised about that, because papillary microcarcinoma is not a threat to survival in the first place. So, as I said, I want to just also share a little bit of personal experience and some thoughts about how this might fit into your practice. And in Edinburgh, we looked at what would be the impact of an active surveillance program on our population. And so we extracted from our database all the papillary microcarcinomas, of the last 10 years. And interestingly, almost all of them in our practice are excised either as part of a benign operation for something else, like a benign disease, multinodular goiter or Graves' disease. A few present with neck node metastases. A few are actually excised as part of, excising a different thyroid nodule and something incidental in the background. And a very small percentage, about 8 to 9%, come to us with a microcarcinoma as an incidental finding on imaging, and a not inconsequential number of those are discovered overseas. Now, this is because in the UK, the British Thyroid Association recommends not investigating incidental thyroid nodules, not unless there's some reason for clinical concern. And so I kind of, to draw to a close on active surveillance, as I said, tumors that you actively surveil tend to grow slowly. Patients tend to adhere, and survival is great if you choose this route of treatment or surveillance. But ideally, you want to design methods not to detect them in the first place, rather than coming up with great methods to follow people and once you've made the diagnosis. And I think that that's something to think about on the wider front before you meet them. So those are the lowest risk cases, the papillary microcarcinomas. But hopefully you're not seeing too many of those. And the mainstay of surgical practice for most people will be intrathyroid tumors up to about 4 centimeters in size. And this is what the American Thyroid Association might classify as low, but not lowest risk. And you can see even some disease with small volume lymph nodes incidentally excised, multifocal papillary cancers, minimally invasive, and intrathyroid tumors. So for most of you, this is probably what you're managing. And going back to 2009 here, the 2009, as recently as that, for all of these patients, total thyroidectomy and radioactive iodine was the standard, excluding the microcarcinomas from that. But for the majority of patients, there was a one-size-fits-all treatment. They all got a total thyroid, they all got iodine, and some people consider central neck dissection in a prophylactic setting too. But it had been controversial for a long time because of mounting evidence that low-risk patients didn't benefit from an aggressive approach, and indeed a recognition that maybe complications could exceed benefit in this population. So I want to try and unpick this because sometimes it all gets bundled into one. But the reason, perhaps the reason we do a total thyroidectomy is because you can't give radioactive iodine without it. And there's been a lot of progress in this field of looking at what's the role of radioactive iodine. So these are two studies, one randomized trial from the UK and one from Europe, Estimable, and the high-low studies that looked at what was the difference between high and low dose radioactive iodine in outcome for patients with these low-risk thyroid cancers. And perhaps unsurprisingly, in a group of patients with very few results and in a non-inferiority setting, these groups were able to show that there was no difference in outcome between high dose and low dose radioactive iodine. And these two papers came out in the New England Journal in the same edition. They did look also at the TSH stimulation, but just focus for a little while on the radioactive iodine dose. And this was the early evidence that high and low dose iodine resulted in the same outcome. Now, of course, critics said, well, low dose should have been no dose. And and what's very new in this field is the Estimable 2, the follow-up to this, took patients in Europe and France with less than 2 centimeter intrathyroid tumors. They all underwent total thyroidectomy and were randomized to low-dose iodine or no-dose iodine. And again, you can see the event rate is so tiny here, almost no events, and unsurprisingly, no difference between the two. So when we think what's the role of radioactive iodine in low-risk thyroid cancers and differentiated disease, we've seen that high dose has been shown to be non-inferior to low dose, and low dose is equal to no dose. So if no dose is optimal, because presumably we're going to say that, then how does that affect what primary surgery you're going to do? How does that impact on thyroglobulin monitoring, which we've relied on for so long? And how does that impact on the role of ultrasound, where it might be more relevant if there's a residual thyroid lobe? And how does it impact on cost? And I don't think all of these questions have been answered, but I think this is the next set of questions to be looked at. So if we say we're not going to give high dose and we're not going to give low dose, we're going to give no dose radioactive iodine. One of the questions is, why take out the contralateral lobe? And what's the appropriate extent of primary surgery? And there are arguments for and against a total thyroidectomy for low-risk cancers. It deals with multicentricity, and particularly in papillary cancers, about a third, some units even up to 50%, show that there are multicentric foci of tumor in the other lobe, whether that's other tumors or early lymphatic metastasis is debatable, but one way or another, you get rid of them so they can't present. It allows you to give radioactive iodine, although we've just said, well, we don't need that, do we? It facilitates thyroglobulin monitoring, and if you get rid of the other lobe, you hopefully render them undetectable in terms of thyroglobulin. There are many groups that have shown that it's safe and that you get great oncological outcomes if you do a total thyroidectomy in this setting. But the arguments against it are that although there are rates of multicentricity, contralateral lobar recurrence is extremely rare, that radioactive iodine is not required, as we've already discussed, that the concept, I've always thought that the concept that you should be more aggressive surgically to make your follow-up easier is flawed. And if total thyroidectomy is a safe operation, well, there's no doubt that thyroid lobectomy is safer, and we'll look at that. And again, you get great oncological outcomes if you treat with less than total thyroidectomy. So this is some data that we had in New York when I was working there. You can see that if you take these patients, 100% of them survive. As we said, survival really isn't relevant to this group, and the recurrence-free survival is extremely good at the 10-year point. When we looked at the difference between lobectomy and total thyroidectomy, we were able to show that really there were no local recurrence. By that I mean recurrence in the same site that you took out. This just doesn't happen. Neck recurrence-free survival is desperately rare, as is distant recurrence-free survival, and overall survival is, patients don't die of the disease. However, if you do a less than total thyroidectomy, our experience was that 10% of patients ended up needing the other side out. And that's one of the criticisms, that if you do a hemithyroidectomy, you do leave a lobe in, and some of them need taken out. And critics say, well, patients don't like to recur. And I think it's the wrong way around. So look at this, because that's true. Let's say 9%, let's just say 10%, half of those, or 5%, were in fact benign nodular disease that was suspicious or whatever. It's difficult to sit on that with a previous diagnosis of cancer. So that meant only half of these patients were actually malignant. And I think the better way of looking at it is that 91% of the lobectomy group were saved a total thyroidectomy. So they had some natural hormone and so on. But if we look at complications, well, there's lots of series showing the safety of total thyroidectomy in expert hands. But this Italian group looked at 15,000 patients operated over 5 years in Italy, and were able to show, perhaps unsurprisingly, that if you do a bilateral lobar resection, so a total thyroidectomy, nerve injury rate was 4%, but if you do the hemithyroidectomy, it was 2%. So if you take out one lobe, it's 2%. If you take out two lobes, it's 4%. And that seems fairly reasonable to me, that if you do double the surgery, you're likely to have double the complication rates. And of course, we don't really see hypocalcemia in the hemithyroidectomy setting, but permanent hypocalcemia is a real problem for patients' quality of life and overall outcome. And that was 2% in this particular series. This is another famous paper done in America. And this looked at two things: the rate of complications and the association with volume, because this has been one of the arguments is that high volume surgeons don't get complications. And then they looked at huge numbers in a national database here. And just to look at the low, intermediate, and high, you can see that the higher the volume in unilateral thyroid surgery, the lower the risk of complication, falling from 12 to 7 or 8%. So that's what we expect to see, that there's an association with volume. But again, like the Italian paper, what you can see is if you do hemi versus total, you double your rates of complication in the total group. So we've got a 12% risk of complication in the low volume surgeons versus 24%. It's almost exact. 9.9% goes to 18.8%, and in the highest volume surgeons, 7.5% go up to 14.5%. So almost exactly a doubling for double the surgery. And so I think it's now not debatable that total thyroidectomy can be achieved at scale without complication rates, which are higher than that in thyroid lobectomies. So thinking about your practice, if you're going to offer thyroid lobectomy, you should be aware that it gives excellent disease control. It minimizes complication rates. It leaves patients with some natural thyroxine and parathyroids on the other side. And there's some argument for whether quality of life's better with a bit of thyroxine on board, but a few may require completion at some point. And I think the way that that's discussed is probably critical. So we've talked here about the low-risk cases, and I would argue that for most of you, these are probably the cases that you're seeing in your standard practice most of the time. And this became more mainstream in 2015 when the American Association guidelines endorsed a more conservative approach for thyroid cancer. Now, the British guidelines are about to be updated and will do the same. But we're seeing this across the world that now a conservative approach to treating these patients is becoming more mainstream. But it doesn't happen immediately. Now, as I said, the British guidelines aren't updated yet. They were last updated in 2014. But we did a survey of groups in the UK and asked we asked a load of things, but this was a simple question: low-risk thyroid cancer, do you recommend hemi or total thyroidectomy? And you can see the span of responses from at the top. Some institutions almost exclusively recommending total thyroidectomy, whereas at the bottom of the graph, some are recommending entirely hemithyroidectomy in that setting. And that's confusing for patients. The two sisters who live close by can go to different hospitals and be given a completely different answers to the optimal treatment for their tumors, even if the tumors are the same. And that's very confusing for patients, and it's kind of an unacceptable problem. So there remain unanswered questions for this large group of patients. And that's partly because prospective evidence is lacking. We don't know how long to follow people up. We don't know how to follow them up. We don't know, does it impact on anxiety? Patients with thyroid cancer are said to have high anxiety rates, although I do wonder if that's how we talk to them about the disease. And how does it impact on quality of life? You know, that anxiety might play a role, but there's no doubt that a recurrent laryngeal nerve injury or permanent hypoparathyroidism has a massive impact on patient quality of life. So we're hoping we can answer some of these questions in the UK with our next iteration of the kind of follow-on study from the RAI studies, is to say, if we don't need RAI, well, can we just take out half versus the entire thyroid? And I'm very hopeful we can show that total thyroidectomy is not required in an RCT setting. So we've talked about very low risk, we've talked about low risk, and now I want to jump to the top and beyond the top of the risk stratification spectrum as presented by the ATA, and move on to what's happening in anaplastic thyroid cancer. So most of you will be familiar with this, and I don't think it's controversial or new to say it tends to present with advanced disease. It tends to present in elderly patients. It tends to be rapidly progressive. It tends to be universally fatal, and that it's treatment resistant. And this is probably what we teach our residents to understand about anaplastic thyroid cancer. But there are very promising advances being seen in this field. And this is a US study that looked at a combination of dabrafenib and trametinib in patients with metastatic BRAF 600 mutant anaplastic thyroid cancer, and really with some remarkable results. This group were able to show that in a small number of patients who had these specific mutated anaplastic thyroid cancers, they were able to see an overall response rate of 69% and a 12-month progression-free survival of 90%, which is really tremendous results. And you can see they provide some pictures here of the kind of responses they saw. You can see some mediastinal disease shrinking away here. You can see again the arrows denote the disease, really significant improvement here in pulmonary metastasis. And this is treatment outcomes which are unheard of in anaplastic thyroid cancer, which has had such a grave prognosis for so long. And you can see here that, again, a huge number of partial responses, one complete response, some stable disease, and really a small number of progressive disease. And there's not a huge number of patients who have anaplastic and are BRAF positive, but if you can find them, then this group of patients have a treatment option now in a way that they didn't have before. And one of the things that I come back to this concept of how would you translate that into your practice? Because I read this and listened to a podcast about it, and I thought, wow, we really should be offering this, but we don't have the firepower of MD Anderson. And it got me thinking about the local processes that are in place in Edinburgh. So I spoke to the individuals involved, and particularly pathology is critical here. And the concept was, I thought, understand the pathways about how does a patient come in, how do they get assessed, biopsied, how do we get the specimens across, What do we do with those specimens, and how can we do it better? Because the standard in Edinburgh used to be that an elderly patient would be admitted with a rapidly enlarging mass. The on-call team, often otology or rhinology, not particularly interested in head and neck, would understand that they're not got long to live. They wouldn't be too urgent. Maybe they get a CT scan a few days later, a biopsy a few days later, and the whole thing becomes strung out over a long period. And this is how we've translated it into our pathway. It would be different for you, where patients get admitted. There's a first aid discussion with the cancer team. They get urgent biopsies. They're taxied straight to the pathologist. The pathologist understands that the BRAF mutation, if it's anaplastic, is critical. And they then fast track that so the oncologist can be aware, and so we can consider systemic options in the appropriate patient. Now, in practice, many of these patients are very old. They are not fit for systemic therapy, and the whole pathway ends at the first moment. But at the same time, understanding it, I think in Houston, they use a circulating DNA liquid biopsy. We don't have access to that kind of technology, but even without it, it is possible to translate this kind of treatment into your own local practice with a bit of thought. So I just want to finish now with a couple of slides on non-anaplastic advanced cancers. Now these are fairly rare. They don't move as fast as anaplastic. Often you think they might be anaplastic when they present. And it's important to understand that if you get one of these with advanced local disease eating into the trachea or in the esophagus, then optimal outcomes are associated with a complete resection, radioactive iodine, external beam in some cases. And really, if you're coming across these and you're not familiar with this, you want to be referring to a center with experience in managing them. And when we looked at this, again, this is New York data, that we're able to show that in the older and in the younger groups, if you can get this thing out, the patient does best. Now that may be actually more to do with the biology of the disease that you can get out rather than the margin itself. But nonetheless, the best treatment is a total excision and then adjuvant therapy. But what do you do if you can't resect it? Well, really, there historically weren't any options for these patients because radiation doesn't really work, chemotherapy doesn't work, and then incomplete resection is just anathema to a head and neck surgeon. So you can potentially lose control of the central neck, and it's a terrible way to die. But there are now been a few studies looking at the concept of neoadjuvant tyrosine kinase therapy. There's a few case series and a few case studies coming out, and I believe there's some work going on prospectively in the States and maybe in a multi-center setting. Now, we've had a few of these in the UK. This was a 74-year-old lady who presented. She had COPD, pulmonary nodules, short, overweight, and she had a long tracheal segment that was involved with what turned out to be a papillary thyroid cancer. She was admitted through the medics with stridor and hemoptysis, and CT chest showed the disease on the top right here. So I took her to theatre to debulk that and get a tissue biopsy. And as I say, that was a papillary cancer. She was deemed unresectable based on her comorbidities and the extent of disease. And we put her on kinase inhibition. She needed dose modification and 2 different drugs. But after 18 months, this thing has shrunk considerably. I went in and did a kind of debulking total thyroidectomy without airway resection. She was then treated with radioactive iodine and indeed external beam, and has this area of abnormality, but we're almost 5 years later now, and she really doesn't have any evidence of active disease in the local site. The pulmonary nodules have turned out to be M1 disease, and that's what's probably going to get her in the long term. This was a psychiatric nurse who presented, and the first thing he said to me is, I'm not having a laryngectomy, but you can see he's got significant disease in his airway. He actually had a Hürthle cell carcinoma, but wouldn't consent to total laryngectomy, which would have been my treatment of choice for this guy. And so he was another one we put on TKI therapy. Interestingly, he fistulated into his tumor. Didn't really matter because it didn't reach the great vessels, but this is one of the risks of this treatment. And when we eventually got him down to this size, I went in and did a tracheal resection. He then received radioactive iodine, and again, his local site is free of disease. So we've got limited experience of this. One of our 5 patients didn't tolerate TKIs, got Stevens-Johnson syndrome, but of the remaining 4, all have done well. Nobody's developed any central neck disease. And this is a promising approach to patients with unresectable differentiated disease. So this isn't an alternative to aggressive surgery, but it shows that some patients, both the anaplastics and these more aggressive, there may be a role for systemic therapy. In this group of patients, fistulation can be an issue, and I still don't know about long-term outcomes. But I think it shows that if we think about what's new in thyroid cancer, that we've seen that staging has changed, and we're going to see a significant number of patients now downstaged. In the lowest risk cases, ideally, you want to have a system that doesn't pick them up. But if you are picking them up, you should be aware of active surveillance and consider adopting it into your practice, because the experience is that these patients are safely managed and do great. But the majority of cases with intrathyroid differentiated cancers, we now know that high-dose radioactive iodine isn't required. Even low-dose radioactive iodine may not be required, and lobectomy may be adequate for the vast majority of these patients. In a small minority of those patients who present with the most aggressive disease, should be thinking of sending these patients to tertiary referral centers, because there are targeted therapies that show promise for some patients. And by thinking about how that impacts on you, you can be ready for them and do the best job you can when they present. So that's what I'm going to say is new in thyroid cancer. Thank you from Edinburgh, and back to the hosts.
Thank you, Ian, for a masterful presentation covering that spectrum of malignant behavior of this remarkable disease. It always strikes me that one of the most interesting things about thyroid cancer is just how vast the span is between the papillary microcancers that carry essentially no risk to life or limb, even if you don't treat them, all the way through to anaplastic thyroid cancer, which is one of the most devastating cancers known to human beings. And that span of malignant behavior, I think, is quite remarkable and a source of great fascination. I do have a couple of questions that I want to fire at you before we bring the panel on board, if that's already in. You talked about anaplastic thyroid cancer, BRAF positive, being very responsive to combined MEK-BRAF inhibition. The question I have, though, is what is the role for surgery in those patients now? If they respond so well to that treatment, should we even be operating, even if the disease is technically operable?
Yeah, well, I think it's going to be an individualized answer to that, because some patients are not going to be, some patients are, our experience is that some patients are not fit from the get-go for these. So even if they have a tumor that might be responsive, that actually their systemic comorbidities preclude surgery or preclude aggressive treatment. But in those that do respond, and it's early days, because that paper came from 2018, I think it was published. So there's a limited amount of experience. But really what you're probably trying to do is avoid asphyxiation at all costs. In some respects, you'd like them to die of distant disease rather than uncontrolled central neck disease. So if you can get them to a situation where they have resectable disease in the central neck, then I think that's a good call. Although heroics like esophageal resection, for example, would probably be a bridge too far in our hands. But I have limited experience of it. I bet you that some panel members will have more experience of it.
So with that, let me pivot to the panel and just introduce our panelists briefly and get started on some of these discussions. I think all of you in the audience, and certainly all of our panelists here, know these individuals very, very well indeed. But it's my real pleasure to introduce Dr. Ashok Shah, who is a surgeon, masterful surgeon at Memorial Sloan Kettering Cancer Center in New York City, and a mentor to many of us for many, many years. Ashok, welcome. Thank you for joining us.
Thank you very much.
Next up is my friend and colleague, Jeremy Freeman, again, a remarkable surgeon from the University of Toronto and Mount Sinai Hospital in Toronto, Canada. Dr. Freeman has been involved in educating surgeons across the world through what I believe to be one of the best training programs for head and neck surgeons anywhere. Jeremy, it's great to have you on this panel as well. The final panelist is Dr. Fernanda Weissman. Dr. Weissman, an endocrinologist in Rio de Janeiro, Brazil. It's good to have you on board, Fernanda, because I believe it's just you and me against these surgical guys. So I'm glad I have a little bit of backup here today. So we were talking a little bit about the anaplastic thyroid cancer. So let me ask Ashok, if you can, just tell us your perspective today on management of surgical management of anaplastic thyroid cancer in Memorial Sloan Kettering. How quickly can you get that BRAF analysis? Do you operate on these patients when they're BRAF positive, or do you send them off to the medical oncologists?
I think that's a great question. It's a very big question, but I'm going to kind of summarize in a very short time. You ask about how fast can we get BRAF. We can get BRAF within 8 to 24 hours with immunohistochemistry. And I think that is quite sufficient. The only thing is we have to tell the cytologist, don't worry about the biopsy done outside. Get a new biopsy the day you see them. And we can do that. And within 8 to 24 hours, we get the answer. The minute we know there is anaplastic thyroid cancer, the email trail begins from the referral department to myself, to endocrinologist, to medical oncologist, to radiation oncologist. So everybody is on board within a matter of few hours. So practically, we can start the treatment within 24 to 48 hours after seeing the patient. Now, the whole idea of anaplastic thyroid cancer has changed. The average survival, which used to be 3 months, is now probably extended to more than 18 and 24 months in my experience. And the second thing we have noticed, the people who used to die with anaplastic thyroid cancer, asphyxiation, we don't see that anymore. Most of the patients die of brain metastasis, liver metastasis. So the quality of life and quality of death has changed quite a bit. So that is one. The second thing is the anaplastic cancer. I mean, we now divide it into BRAF positive, BRAF negative. But let's go back to the history. We knew the three types of anaplastic thyroid cancer. The one de novo, which is giant and spindle cell tumors involving both sides of the thyroid, massive disease involving the trachea. Those were technically unresectable to begin with and probably unresectable throughout the course of their patients, their treatment. The second course, which is a multinodular goiter, benign goiter transforming into cancer, probably a surgical option if it is a localized disease. And the third one, which is a papillary carcinoma involving one lobe of the thyroid, patient getting older, tumor getting bigger, and transforming into anaplastic thyroid cancer. I think these are the three different varieties of anaplastic thyroid cancer that as a clinician we need to appreciate. What we learned with this treatment, abrapnib, imatinib, and sometimes pembro, is the tumor which was inoperable is now probably surgically resectable. We rarely would consider resecting the trachea or the landings in anaplastic thyroid cancer. But can we technically resect the tumor? Yes. What we have noticed in few cases we have done, and the similar experience comes from MD Anderson, this classical anaplastic thyroid cancer, after the treatment, when we operate, all that we see is a papillary carcinoma. The anaplastic form has disappeared. This is a major biological understanding, and it tells us that the papillary cancer, where the patient started initially, went on to anaplastic, is now regressed back or reverted back to the control of anaplastic and residual papillary carcinoma. That's the one we should surgically resect. Who should be resected? To answer your question, the tumor which has receded well, and the surgeon feels he can take it out without major morbidity to the patient. And how do we do it? We restrict our surgery to neck dissection on the side of the disease, bulky disease, and a lobectomy. We try to avoid total thyroidectomy and nerve injury on both sides. Remember, majority of these patients have one paralyzed vocal cord. So critical aspect of this care is remove all the gross disease, avoid any major complications such as airway distress or coil leak. And the third, then follow them with a combination of chemotherapy and radiation therapy. I think we have seen a major paradigm shift in the quality of these patients, the overall survival, and the way they live and the way they die.
Thank you, Ashok. I agree, I think 100% with your commentary there. Fernanda, tell us how things go in Brazil with anaplastic these days. Do you have easy access to the BRAF mutation? Can you use these MEK and BRAF inhibitors?
Thank you, Brian. One of the things that Ashok just mentioned that is critical here, we have limited access to molecular biology. And sometimes we have this argument if immunohistochemistry is enough for that. And in the few cases that we had here, that we were able to confirm the immunohistochemistry, they were negative and were supposedly false negative. When we double check with molecular biology, they were all negative. So what we learned is that immunohistochemistry, which is widely more available to a lot of services, in those anaplastic cases, they might be enough, and they are easier to do, they are cheaper, and they are quicker. So I think this is critical for what we're doing here. So this was a great discussion here, like 2 or 3 months ago, because we had 2 or 3 cases in a row, unfortunately, and they were all confirmed. If they were positive in the immunohistochemistry, of course, they were positive in the molecular biology, but the other way around was also true. We have limited access to a lot of drugs, but we do have BRAF inhibitors. So we sometimes use them alone because it's hard to approve this combination therapy. And we've seen some progress. So we've seen here as well this shift that Ashok just mentioned. So patients are dying from distant disease instead of neck disease, which is, of course, a nicer, if you can say like this, way to end your life.
Yeah, I certainly agree that the transformation in our ability to care for patients with anaplastic and other aggressive forms of thyroid cancer is one of the most remarkable shifts that I've seen in my career. We've gone from having no therapies that had any chance of working and therefore therapeutic nihilism, all the way now to treatments that can result in a few cases in complete remission. And then the question is, how long do we keep patients on these drugs? That's a good problem to have. Jeremy, what about in Toronto? Do you follow these same approaches with early molecular testing in the anaplastics? And how do you act?
Well, as Ashok said, and Ashok just gave a master class on how to deal with anaplastic carcinoma. I have not much to add, except that there's been a major paradigm shift, of course, when people with this horrible disease were relegated to death and not much we can do except palliate, to active treatment. Just one comment is, over the years, I have failed miserably in these advanced anaplastic carcinomas with any surgical approach and any adjuvant treatment thereafter. But current management techniques given by our medical oncology colleagues have really revolutionized this treatment, as you say. Basically, our operative approach, at least my personal operative approach, because everything is still a hodgepodge in terms of treatment. There's no uniformity of treatment around the world, but I tend to classify these from a surgical point of view as big A and little a anaplastics. The big A ones are the ones we've all seen, which are massively invasive, probably have METs, probably have some sort of organ dysfunction, to a anaplastic carcinoma that looks much like a papillary carcinoma, which is probably in the earlier intermediate stage of development, which is surgically resectable. So that's basically our approach, very similar to the Memorial approach, very similar to the Anderson approach. And again, it's just it's gratifying to see this nascent approach that's given these people hope for at least a long-term palliation.
Robbie, I know, is monitoring the chat, and there may be additional questions around the anaplastic, but I did want to make one kind of generalized comment, and that is that what we've learned in the last decade or so is that clinical trials in thyroid cancer are not only possible, they're essential. And it's remarkable to see Ian talking about clinical trials with radioactive iodine, for example, which back in when I was a fellow, we were told we would never be able to do that. There were far too few patients. There was no funding for it. And too few of those patients died to get any realistic results. And yet here we are, a couple of decades later with multiple clinical trials and multiple agents coming down the pipeline towards us. So we owe it to our patients to make sure that if a clinical trial is available, we refer those patients to those clinical trials so that we can learn more and treat these patients better in the future. So Robbie, you feel free to jump in with questions if there are any. I'm just going to scoot on to our first case, though, while you're getting ready for that. I do want to mention I do have a few conflicts of interest listed on the screen here. I know that if anyone else has conflicts of interest that are relevant, they can let us know. So case number one that we want to talk about it doesn't look like an anaplastic here. You can see the ultrasound scan. This is a 52-year-old man. He has a lump in his neck, turns out to be in his thyroid gland. And the ultrasound reveals a 4.2 centimeter, apparently solitary thyroid nodule. Screening of the neck shows no suspicious lymph nodes. A biopsy is performed, which I think all of us would be comfortable in recommending. And it shows a follicular lesion with scanty colloid classified by the pathologist as a Bethesda 4, a follicular neoplasm or suspicious for follicular neoplasm. So let's talk a little bit about the underlying likely risk of malignancy, how this patient should be managed. Should we be repeating a fine needle biopsy to get a more definitive diagnosis? What's the role for molecular markers? So let me start off with Ian, if I can. Ian, in your assessment, what is the actual risk of malignancy in a 4 centimeter Bethesda 4 thyroid nodule?
Yeah, in our hands in Edinburgh, it's
Ian, I've lost you. Okay, I think we've lost sound from Ian there. So, Jeremy, what about in Toronto? Risk of malignancy?
Well, in the old days, using Mike Tuttle's risk stratification scale, this man's risks are advancing towards middle age or old age in the old days, a large nodule with a atypical biopsy. So he is an intermediate, almost bordering on a high risk patient to have a malignancy. Nowadays, with our confidence in fine needle aspirates and our confidence in molecular markers, that's kind of up the ante. So I would like to know if this patient went on to any sort of molecular marker. We used to operate on all of these. And what we did was a thyroidectomy commensurate with the possibility of malignancy. So we found that 50% of these did not have any malignancy in them at all. We therefore changed our clinical approach to these patients and offered patients, and in fact, made patients partners in their treatment and offered them either surveillance, surgery, if it was a quality of life issue and they couldn't bear the fact of having a thyroid lump that had some risk of malignancy, or we offered them molecular markers, which in Canada patients have to pay out of their own pocket, and based our management on that. And, it was a hodgepodge of patients which chose each of the three options. But I must say, I've been gratified with that approach. And I must also say that none of our patients, I'm talking about hundreds of patients who have given that secondary option type of treatment, have gone on to have a bad malignancy that was incurable. Some of them did go on to have malignancies because we did monitor them going forward, but all of those were salvaged and none of them that I can remember died of their disease.
Yeah, it's important to remember there's rarely an emergency in these kind of low or intermediate risk types of thyroid cancer. So we've got time on our side to do some observation over time. Overall risk of malignancy in a Bethesda 4 in the literature averages out around 30%, but it's remarkable just how broad the range is. It can range anywhere from 0% in some centers all the way to 75% in other centers. So you really have to know your pathologist if you're going to really interpret their call for a Bethesda 4. Fernanda, your experience in Brazil.
I think another key thing here, Brian, is to associate with the risk conferred by the ultrasound. So we've been seeing some studies that you can lower this if the ultrasound is low suspicious. You get it higher if it's a high suspicious ultrasound, and maybe not even do molecular testing. If you have a very high suspicious ultrasound with a Bethesda 4, maybe you don't need the molecular testing that in Brazil our patients already also have to pay out of their own pocket. So I believe you have to, order molecular testings if this will alter your management. So if I have a very low suspicious ultrasound with sometimes a long, an old nodule that a patient knows for 10 years, and okay, it's big, but it's not growing, you see that it's a lesion that's confined to the thyroid. Maybe I can follow this. And if I have a very high suspicious ultrasound with the Bethesda 4, maybe I'll operate it anyway. So I think we might not need the molecular testing. And if this in between, maybe the case you're presenting, it's an intermediate ultrasound with an intermediate FNA, then I think the molecular testing have a very important role here.
Yeah, that's really important point, that we should never throw the baby out with the bathwater, right? We should always integrate the clinical findings, the ultrasound findings, the pathology findings, if we're going to do it, the molecular findings, and put that together as a package. Because a very high risk ultrasound with a benign biopsy, I'm tempted not to believe the biopsy. Because of the risk of malignancy in those very high risk nodules, I'd be willing at least to consider the repeat FNA. Mm-hmm. It's also true that repeat fine needle aspiration biopsy can yield reliable results, especially in these lower risk nodules on ultrasound. If you get a Bethesda 3 in particular, but sometimes a Bethesda 4, and you repeat the biopsy and it comes back Bethesda 2 or benign, that's a reliable benign call in most cases with about a 97% negative predictive value. But nonetheless, molecular markers increasingly being used, at least here in North America, and in the US, a lot of the payers are using that. And so this patient did go on to have a molecular test, and it revealed a mutation in NRAS. So does that change your perspective, Ashok? How would you approach a RAS mutated 4-centimeter nodule?
I think, let's go back to the whole case. 52-year-old man, 4.5 centimeters, solid nodule. Needle biopsy does not show colloid goiter. Remember that. It shows a neoplasm, whatever you want to call it, AUS plus. The only way you can find out he has cancer is look at the whole capsule. And that's the way you are going to distinguish between follicular adenoma and carcinoma and vascular invasion, etc. What does the RAS mutation tells me? It tells me that this is not a benign goiter. Is that helpful to me? Yes. Is this a patient for RFA? Not in my books. The classical follicular hyperplasia, a nodule, perfectly okay. Not in this guy. The other thing, I go very practically, Let's say, Brian, you are 52, you have this nodule. Am I going to monitor you for next 48 years? With a fear that this may grow 1 millimeter, 2 millimeter. He has already lived last 20 years with this nodule. So the nature has already told you that I have come to 4.2 centimeters. Don't wait till 7.5 centimeters. It needs to come out. I don't mean to say you need to operate today. If you want to give a benefit of doubt, 6 months is fine, but it's not going to change in 6 months. This man is to be scheduled for surgery at an opportune time of the surgeon and the patient, with an understanding that his risk of having cancer is more than 50%. The classical textbook 30%, forget in this case. Man, solid, needle biopsy is atypical, RAS mutation. Now you can argue that the RAS mutation is a low risk mutation, understandable. But we don't have a diagnostic, and that's why I call these operations diagnostic and therapeutic lobectomy. The surgeon should make the best decision in the operating room. Get a good CAT scan. Look at the paratracheal lymph node. Be smart before operating on the patient. At the time of surgery, if there are suspicious lymph nodes, and many, they are positive, proceed with total thyroidectomy. Otherwise, this is why I call this diagnostic and therapeutic lobectomy. The final report comes as minimally invasive follicular carcinoma. Done, you have cured the patient. So we have major vascular invasion when we talk about coming back.
So, Jeremy, how big a surgery does this man need? Is a lobe enough? Does he need a total thyroidectomy? Because if this is a 4-centimeter cancer, surely you want a total thyroidectomy, don't you?
So I'm going on my personal experience with this, and this is unpublished, but I can tell you we've had many, many KRAS, NRAS mutations. I don't think I'm allowed to say which lab we use, but nonetheless, I can tell you with absolute certainty, with a KRAS or NRAS mutation, we've offered every patient surgery. They now have a higher risk stratum. And I can tell you with certainty as well that every patient that we've operated on with an NRAS or KRAS mutation, I'm sure there's outliers out there, but every one of these has turned out to be malignant. So given that information and given the ATA guidelines about size of lesion, and then what sort of surgery do you do, we do total thyroidectomies for these because it's greater than 4 centimeters. And as I said, they've all turned out to have cancer, and I can't think of anyone who's done poorly using this paradigm.
Fernanda, help me out here. Surely this man is a diagnostic lobectomy, doesn't he? I mean, these aggressive surgeons trying to take the whole thyroid out. Isn't it better to leave the other half in place and then he doesn't need thyroid hormone?
So my surgeons down here would argue that you can do a frozen section, and you start like a whole new discussion with the surgeons all around the world. So we can add this little thing in our game here. But in our practice, he will do a diagnostic lobectomy and maybe come back later for another. So we live in a huge country, not a lot of head and neck surgeons. So I think we have to think about this as well. So some of those patients are operated by general surgeons. So that favors more a diagnostic lobectomy because the risk of complications is even higher with a total lobectomy in a non-experienced hand. But I think both approaches are right. I mean, if you can support one or the other. It's a big tumor. It can be a big tumor. You're not going to have to come back later. But in our hands, he will go for a diagnostic lobectomy and maybe come back later if this turns out to be malignant.
So the key, though, and I think you've said it beautifully, the key is to make sure the patient is aware that if we're going to do a lobe, they may well need a completion thyroidectomy because these bigger tumors, even though they're solitary RAS mutation driven, will sometimes have adverse pathologic features on final pathology that you think maybe I should have done the total and exposed that patient to radioactive iodine. So vascular invasion, more extensive capsular invasion than you were expecting, some of those can be indications to move ahead with adjuvant therapy. But I think, typically for us, we find the risk of malignancy being a bit lower than Jeremy's describing. And so we generally do a therapeutic lobectomy with the option to do a completion thyroidectomy at a later date if necessary. Robbie, I see you've come on. I presume there's some questions in the chat here.
Yeah, so there's 3 questions so far directed at Dr. Nixon's talk. So I was thinking we might save those ones for the Q&A at the end and just focus on the cases. And if there are any questions on the cases, we can jump in and ask those questions because we have 10 minutes for Q&A at 10:35. So we might just save those 3 questions for that particular point and just work through the cases for the next.
Great.
Brian, can I just say 1 minute here?
Yep.
I think Fernanda is correct. And you have to understand the culture and the ethos of the society you're dealing with. In Canada, in our jurisdiction, patients don't want to go to surgery. So we're looking for reasons not to put patients through an operation. I'm sure it's much the same in New York. But once they go for surgery, they want to have definitive surgery. They don't want to come back for a completion procedure. So with our high incidence of cancer and RAS mutations, yes, we encourage surgery, but we still give them the option of not having surgery with close follow-up and surveillance. But once they have their surgery, they don't want to come back anymore. So they don't really care if it's a negative result as long as they have one operation.
Yeah, so customizing this for the patient and also for the surgical skill set you have available is really key. Ashok, looks like you want to say something further.
I just want to say about this one operation versus 2 operations. I hear this all the time. When you tell the patient in a confidence that, look, I'm going to take out one side and there is a remote possibility you may need completion, which is very selected. If you prepare the patient very well, you evaluate with a good ultrasound, good CAT scan, the possibility of requiring second operation is less than 5%. The textbooks and many of the publications say 40%. That's not correct in my judgment. It's only 5% with adverse pathological features. The clinical features are to be judged with a preoperative ultrasound, CAT scan, intraoperative decision making by the surgeon. If I see 10 positive nodes, I'm not going to wake up the patient. I'm prepared the patient for total thyroidectomy. Or I see a gross extracellular extension. If we exclude those patients, the only ones who require completion are the ones with major vascular invasion, which you cannot appreciate till the pathology and report is given. And that happens only in less than 10%. So I need to make sure that we don't make it very easy on the patient. Oh, don't worry, I'll do one operation, get total thyroidectomy, and you don't have to worry about it. No, the endocrinologist will be worrying about it for the rest of his or her life, not the surgeon. Surgeon is on a beach.
But Brian, if I may, with all due respect to my intelligent and esteemed colleague, with our RAS mutations, almost 100% of them have cancer. So we have to go with the numbers and the science. And if we offer them a lesson total, the chances in our jurisdiction are that almost all of them will have to come back for a second operation.
Yeah, so, again, I think that these are experiences that need to be published, because right now out there in the literature, RAS mutations are supposed to have about a 35 to 40% risk of malignancy. You're describing 100% risk of malignancy. That's a little bit of an outlier. We got to get those data out there. Our own experience is closer to that 30 to 40%, but again, I think a lot depends on the way these patients are being selected and which nodules you're biopsying. Thinking about that pre-op workup, Dr. Shaha said CT scan. That used to be very controversial in endocrine circles. Ian, in Scotland, do you do CT scans routinely on patients before thyroid surgery?
Not unless we think they have invasive disease or nodal disease, or there's some reason to suspect distant disease. So sorry, I cut out for a minute and then back in, but we wouldn't routinely CT this patient.
Okay, and what about the role for ultrasound? This is a RAS-driven tumor. What's the likelihood it's going to involve lymph nodes? Pretty small, I think, isn't it, Fernanda?
Yes. Pretty
So
small.
is there a value to ultrasound the neck?
Yes, we still do it. We still do it because it can be a follicular variant of papillary, and it might have lymph nodes. And I think we should do it even with either in a RAS mutant. What I would say is like the RAS rate of malignancy is also controversial if you include NIFT-P in or out, if you're talking about the risk of malignancy. So maybe it's even lower if we think about real malignant tumor. So I think we have to think about that.
Yeah, life became so much more confusing when we had to move away from a binary construct of cancer versus benign into this spectrum of malignancy. This guy did have his lobectomy done. It was an encapsulated follicular variant of papillary thyroid cancer, just as Dr. Weissman predicted it would be. And that's certainly the most common version of malignancy that we see in our experience with these RAS mutants. So what are the next steps for this patient? Do they need some additional treatment? Do they need observation? How do we handle this? I'll pass that one to Jeremy to start.
Yeah, for these ones, there's still a debate whether these are cancers at all. And my friend Yuri Nikiforov feels that these are not really invasive cancers. These are probably malignancies in evolution. And given the literature on outcomes of these lesions, it appears that the vast majority with the particular operation this patient had are cured. So as far as I'm concerned, all this patient needs is observation with ultrasound. I think the jury's still out about whether these patients need to be suppressed with exogenous thyroid hormone. And most of these patients are going to have a good outcome.
Yeah, so we did the pathology review in the aftermath of the description of the NIFT-P, and this did fit the criteria for the NIFT-P. There was no extracapsular invasion, there was no vascular invasion, there was a little bit of nuclear clearing in grooves, giving it that papillary-like nuclear feature, but no significant papillary histology. It was completely encapsulated. So again, NIFT-P. And I always joke with Yuri Nikiforov about the NIFT-P because the way we manage it is the way Ronald Reagan suggested we should manage the Russians back in the 1980s, which was trust but verify. We trust that this is a benign lesion or a precancerous lesion, but we verify by monitoring it as if it's a low-risk cancer. And so far, in our small experience of NIFTs over the last 4 years or so, we have not seen any of these recur or show evidence that they were true established malignancies.
What did you tell the patient? Did you tell the patient you have benign problem or malignant problem?
I told him he had a colon polyp of the thyroid gland. It's the equivalent of removing a colon polyp which has some dysplasia. It's got malignant potential, but it has not yet transitioned to malignancy. And so long as we nip that little colon polyp off or pop out that lobe of the thyroid gland, chances are they'll go on and live forever. But we should always do the surveillance, just as we would for colon cancer screening.
I use the word pre-cancerous. I think they understand very well why did I go for surgery. And majority of these are women. If you tell them analogy of cervical dysplasia, they understand it very well. That something needs to be done, but nothing radical. I think they understand it very well. I use those two words very commonly.
Yep, I think those kind of analogies are really helpful. So, Robbie, unless you have some additional questions for that case, I'm going to move it right along.
There's a few questions, so we definitely want to get to those, but there's nothing really pertaining to that particular case. So we can either move on to answer some of them now or move on to the next case, whatever you prefer.
Let's move on, because I really want to get at least 3 cases in. We've only got 20 minutes left, so I'm going to run through this one. This is a 56-year-old man, asymptomatic. He has a high suspicion ultrasound nodule, 1.9 centimeters. Biopsy is Bethesda 3 with nuclear atypia. The zinger here is that he's a professional opera singer. And so I'm going to send him immediately up to Memorial Sloan Kettering so that my surgeons don't have to deal with it. So he has molecular testing for this nodule because of the Bethesda 3. It exhibits copy number alterations and gene expression changes and falls into a suspicious category. What the heck are copy number alterations and gene expression changes, and how do we interpret those? Fernanda?
Well, I think this falls in the indeterminate thing here. It's easy when you find a point mutation. It's easy when you find when you find like some fusions. But when you see copy alterations, it's hard because you sometimes don't have the ideal cutoff for benign versus malignant, as we see in microRNA, for example, is the same thing. So sometimes it's difficult to say. And again, you have to combine everything. How's the ultrasound? How was the biopsy? What's the risk of these patients to get any problem during surgery? I think that to weigh the risk and benefits for a surgical treatment, this is not confirming this is a cancer. It's not saying it's not. So I think that's still a residual possibility that you go on operation and you're operating for a benign disease and in a professional singer. And if it's not Dr. Friedman or Dr. Shaha operating on him, I would be afraid.
Yes, quite. So with that in mind, you've got a suspicious looking ultrasound scan. You've got something that's telling you this is not benign on the molecular marker technologies. Jeremy, what would be your pre-op workup, and how extensive would the surgery be in this professional opera singer? Jeremy? Oh, you're on mute, my friend.
How big was the lesion?
Oh, it's about 1.9 centimeters, as I recall, just a little under 2.
Okay. All right, so he has a malignancy, almost 100%. He needs an operation. According to guidelines, he would qualify for a less than total thyroidectomy. I'm going to say something very heretical here, but he also may qualify for active surveillance. And this is something I would offer him, provided that he returns religiously for his post-operative visits. And, in a professional singer who's looking for every possible chance not to have an operation, this may be a consideration, with full disclosure to him that, any chance that this grows or shows any aggressive behavior, we would go on and do surgery. But the standard treatment for this is an operation, a less than total thyroidectomy, a thorough scrutiny of the central compartment. If there are any positive nodes, remove them. And depending on the postoperative pathology report, consideration for RAI if he qualifies.
Ashok, do you want to burn the heretic?
I think, Jeremy said it very well. He's a professional singer. He's 56. There are few questions. I mean, the no-brainer decision is he needs a lobectomy. There's no doubt about that. The question is, can we defer the operation? And that's why I have changed the word in my vocabulary, active surveillance, to close monitoring, or the better yet, deferred intervention. Can we avoid operation in this man for 44 years? No. Can we avoid for 2-3 years? Probably yes. But remember, he and his family, his neighbor and his gardener needs to know it is out of the box approach because of his singing career. No matter who does the operation, me, Jeremy, or Ian Nixon, there is some risk about his voice changes. May not be the same voice changes due to nerve injury, but the architectural changes in the neck, the scarring and fibrosis. He may not be the world's #1 singer anymore. He needs to understand that. If he says, look, I'm not worried about it, I want the cancer out, now the philosophy of minimalist versus maximalist comes. If he's a maximalist, I'll operate on him tomorrow. He says, look, I understand that you have several patients like this. I'll be happy to see in 6 months what happens. In 6 months, I'll sing 10 songs. I'll make $10 million. I'll retire. Perfectly okay. I think this is what I call out of the box approach. And we do this on several patients with a clear understanding of better evaluation. I would also look at the ultrasound critically. Is it an irregular margin or non-irregular margin? If it is an encapsulated lesion, I'm very comfortable monitoring him for 3, 4, 5 years and then come to surgery. I think we need to have the integrated approach, and we are very fortunate at Memorial with some of the best endocrinologists who are directly involved in this complex decision making. If I give the opinion to the patient alone, they don't like it. If I give it with one of our endocrinologists, they say, okay, 2 of the doctors at Sloan Kettering don't want to operate on me. I'm very happy to follow.
Okay, so we've got 4 surgeons on this meeting right now. I want a one-word answer from each of you. Is nerve monitoring helpful to preserve this man's voice or not? Let me start with Robbie.
Yeah, I mean, I think it's really an important part of everyone's practice nowadays. I think that from a medical legal point of view, it's somewhat of almost a requirement to use nerve monitoring these days. But it is extremely useful in practice. And I think that I would imagine the vast majority of surgeons on this meeting would use a nerve monitor in their practice.
Ian, Scotland, using nerve monitors?
Yeah, we're using them routinely. Yeah.
And what about Toronto, Jeremy?
I don't think the nerve monitor helps you with routine surgery. And there is science, there is literature that the incidence of nerve injury is not ameliorated by nerve monitoring in routine cases. It makes the surgeon feel better at the end of the case, and I have no qualms with somebody feeling better after a case, but there is no evidence that it helps you find the nerve, and there's no evidence that the incidence of monitoring makes the outcome better. So the answer for me is a long-winded no, but having said that, I do use it for recurrent cases.
Yeah, so I think that there's a generational divide as much as anything else here. Old guys like us, like you, Jeremy, who've done this for so many years and did it without nerve monitoring, are very comfortable with that. But the young kids like Ian and Robbie are much less comfortable to do without. Ashok, do you fall into the elderly camp or the younger camp?
Whenever there is a question to be asked, don't go this way, don't go that way, stay in the middle, you will be always correct. I think, there are 2 issues in this case. He's a professional singer. So it's not just the recurrent laryngeal nerve, remember that. And I think Jeremy's comments are more pertinent to the recurrent laryngeal nerve. There is some experience, emerging experience, and some publication from the international guidelines about monitoring the superior laryngeal nerve. What I'm not convinced is, does the monitoring of the superior laryngeal nerve does prevent nerve injury to the superior laryngeal nerve? There are three aspects of this professional singer: injury to the superior laryngeal nerve, injury to the recurrent laryngeal nerve, and more importantly, the scarring and fibrosis and the architectural change, which leads to subtle change in his voice or singing. It's like a swimming. You win the game by 0.01 second. That's a similar difference here in singing. His colleagues will tell that after your surgery, you are not the best singer in the world. I'm better than you. And that subtle difference you and me will not notice. Will the nerve monitor help? I think it does help. Jeremy said it very well. It makes us feel good. At the end of the operation, there is a nice stimulus. You can come out and tell, I did a great job. I'm very happy. You are very happy.
So this actually is a real case of mine from a few years ago, and this opera singer had the surgery done with nerve monitoring because our surgeons feel comfortable with that and makes them feel better after the surgery. It turned out to be a minimally invasive Hürthle cell cancer with capsular but no vascular invasion. He did achieve complete resection. There were no lymph nodes involved. We can discuss the role for adjuvant therapy in this setting in a minute, but I will tell you that his voice did subtly change after the procedure, just as Dr. Shaha predicted it would. But he went through vocal coaching and he was back on the circuit within a year. And when I last saw him about 6 months ago, he feels his voice is even better than it used to be. And so he's had a really excellent vocal outcome from that.
Do you need surgery, Brian? You want surgery to improve your voice?
I did the surgery myself to, with a penknife. So this is the pathology. Fernanda, adjuvant therapy for this minimally invasive Hürthle cell cancer. Hürthle cancer is aggressive, right?
Yes, but I'm a staging person. So what I would do now, it's post-operative staging, thyroglobulin, ultrasound. How does the patient is after surgery, and then make the decision, not the pathology report by itself. So if everything turns out zero, no adjuvant therapy for this patient.
That's exactly what the answer I was hoping to hear, because it's really important we don't just go based on a pathology report or indeed a molecular profile. We have to understand the big picture, and staging is so critical in making those decisions. So at this point, I'm going to step back a little bit. I'm going to ask Robbie if he wants to present case number 3 or address any questions that have come through on the chat.
Yeah, there's some questions came through in the chat that I might just address. There was one question about frozen section for follicular lesions and the opinion of the panel on that. So maybe someone could comment more relevant to the first case, but would anyone be willing to give a comment on that? Perhaps Dr. Freeman?
I bet was one of my colleagues.
May have been.
I used to get frozen sections, and because of the high failure rate in identifying the lesion, we don't anymore, especially for follicular lesions, because it is impossible to identify capsular and or vascular invasion on a frozen section. So we would defer to a permanent section on these follicular ones.
Okay, excellent. And there was another question, maybe I'll direct it to Dr. Shaha, about the role of prophylactic neck dissection in these cases we've discussed, just to give your opinion on that.
Virginia Livolsi, one of the famous pathologists from UPenn, some 25 years back, wrote a one-page editorial, and the title of the editorial was "Frozen Section in Thyroid, just say no." For the time of the drugs, and I think that she was absolutely right. I don't think the frozen section is going to tell you something more. The only advantage of frozen section, if there are suspicious lymph nodes, number one, and another one, as a surgeon, you want to know, is it a colloid goiter or a follicular neoplasm? That's the only advantage. Does it change what you're going to do? No. You made that decision on day one when you walked in your office with ultrasound and all the imaging. So I don't think the frozen section will change, but sometimes there is a temptation to see what is going on. One of the major advantage of frozen section is whatever you learn that day is something that you will be in your mind for the rest of your life. Not 10 days later. You forget everything what you did in the operating room. Would I get it for the parathyroid and lymph nodes? Yes. For thyroid itself, it doesn't help much.
Thank you very
Bobby,
much. So,
did Ashraf actually answer the question there?
well, yeah, I suppose it was more in the frozen section, but Dr. really, one of the questions was about the role of prophylactic neck dissection. If you just maybe would give a quick comment on that.
Would I do? Oh, okay, sorry. The prophylactic neck dissection. My God, that's a whole next panel. The answer, I'm going to make it very simple, so that I don't take much time. If the preoperative ultrasound and the intraoperative findings do not show any obvious lymph nodes, the answer is no, capital no, and big no. Make it simple. Brian, does that help you?
That helps me. All right, Robbie, take us off.
So we've 5 or 6 minutes of this last case. So this is a very typical thing that people might see. And so it's a young lady who had a screening ultrasound that picked up an incidental thyroid nodule called ThyroIds 5 on ultrasound imaging, and a negative lateral neck on the ultrasound. So I suppose maybe I'll ask Dr. Weissman. Would you biopsy this, or would you observe this?
Ooh, okay. So it falls like in the cutoff. It's a highly suspicious. It's a high suspicious nodule, hypoechoic. It worries me a little more, but it's 1 centimeter interthyroidal. So usually, in most guidelines, the cutoff is 1. So you should biopsy if it's 1. And I think you can discuss with the lady if she wants it to know what it is, or if you can watch if you want. In my practice, this lady would get an FNA even if it's with me or with somebody else. So probably what I would argue is you can discuss before which are the possibilities that she can have. So even if she had a malignant tumor, she can watch, but she would go until somebody order an FNA for this lady.
Yeah, so if you go to the next slide, just 1 year later, she underwent observation, and it had grown to 1.3 centimeters now. And so at this stage, she underwent an FNA, which showed Bethesda 3 atypia. And let's go to Dr. Nixon. What would your next steps be in this case?
With Bethesda 3s, we often repeat a biopsy, is what we do actually. We do not do molecular testing routinely in the UK. But assuming that was also Bethesda 3, I would go ahead with a diagnostic lobectomy in this setting.
Okay, so yeah, we'll go to the next slide, and the patients did indeed have a repeat FNA, which showed Bethesda 3. And so I guess, as you've answered already, in the UK you wouldn't, but perhaps in the US the patient would have molecular testing. So this patient's pathology was in fact reviewed. If we go to the next part of the slide, and they had lab tests done. And it was actually suspected with these lab tests. What would you be concerned about now, and how would it change your approach, Dr. Nixon?
Yeah, well, I'd be concerned then that this is a medullary thyroid cancer, and regretting not doing this 12 months ago or whenever we engaged with this lady, I suppose. And maybe to look back at the original and say, is there anything we could have determined from that might have pointed it this way? I'd be interested to know about a family history, and there's the old debate about, do you at this point screen them, or do you recommend surgery, which is going to be total thyroidectomy and central neck in this setting, and then test them thereafter.
So maybe we'll go to Dr. Freeman. So this pathology was reviewed and is suspected of medullary thyroid carcinoma. So Dr. Freeman, what would your extent of surgery be in this case of a 1.3 centimeter nodule that's now suspicious from medullary thyroid carcinoma?
I'd like to backtrack a little bit and do more investigations. I'd like to make sure that this patient isn't a MEN type 2. So I would do the appropriate biochemical and radiographic workup, including urine calcitonins. I'd do a CEA. I would do a CT of the head and neck and chest, and probably abdominal ultrasound. Assuming, I'm going to assume that these are all negative. If they were done. So this patient does not have an MEN type 2.
Yes, this is sporadic. Yeah,
it's sporadic. So this patient needs surgery, and the standard surgery for this type of lesion, I mean, it's a female, is it? I can't remember.
A young female, 28 years old.
Yeah, so she would need a total thyroidectomy and, as Ian said, a central neck dissection.
And Dr. Shah, what are your thoughts on management of lymph nodes in this case and in general in medullary thyrocarcinoma?
I think everything has been said very well. This is medullary carcinoma of the thyroid, unless proved otherwise. You can go back to those slides and ask the pathologist to do thyrocalcitonin stain, and it will be positive. So you know it is medullary cancer. The million-dollar question is, do you want to do the mutation of the analysis before or after the operation? If you are a strong believer in total thyroidectomy and central compartment dissection, which is what this patient needs, and that would be considered the gold standard of care, then you can wait for the molecular testing as long as there is no pheochromocytoma. Just get the serum metanephrine that is normal, proceed with surgery next day. Nothing wrong in it. I think you're appropriate. If you have a genetic mutation available and it is a low-risk mutation, like 804, there is a select group of patients where you and your endocrinologist can work together on a lobectomy and central compartment dissection and leave the opposite lobe behind to be monitored with calcitonin, etc. Again, I'm going to say this is out of the box. There is a good experience of non-familial medullary cancer, non-genetic type of medullary cancer in Japan, where they have done a lobectomy. Would I advise that in the United States? No, because we do go ahead with the standard of care, which is total thyroidectomy, appropriate central compartment clearance in this patient, and good monitoring with calcitonin.
Okay, so thank you very much. We have
if I might just interject, I would also have the pathologist stain for red oncogene. Most of our patients, well, the majority of our patients are also sent for genetic counseling, just in case there is a familial aspect to this type of disease.
Absolutely, yeah. So we have about 8 or 9 minutes left, and I think it might be best to address some of the questions. There's a few questions came in on the back of Dr. Nixon's excellent talk. So maybe we'll just address some of those in the last bit of our time with Q&A. So there was a question on if Dr. Nixon could maybe comment on the feasibility of active surveillance in developing countries.
Oh, that's an interesting question. Well, I don't see that the natural history of the disease is going to be any different. So I think you still find that there are these three groups: the increasing, the stable, and even this tiny group of decreasing. I guess the question is the access to resources and the balance of ability to screen people after diagnosis versus the access to surgical intervention. So there will be some countries where it'd be very difficult to get a safe surgery. And in that situation, you're better observing them. But if you have access to safe surgery, but you don't have access to follow-up, then I guess you're better doing the surgery then rather than following them up. But I think that's going to be very individual. Do we have an example of where exactly they mean? Is anywhere more developing than Scotland?
The question came from Brazil, I think, but I think that's the most valid point.
Fernanda may be better place to answer that in Brazil.
So we're doing our own cohort on active surveillance, if this is the short answer for this question. But I think we have to think that we're already doing it on a daily basis in our offices once we don't biopsy very small suspicious intrathyroidal lesions. So in our guidelines in Brazil, they are going to be updated, but lesions less than 0.5 centimeters, even if they're high suspicious, we don't recommend to doing a biopsy, even knowing that this probably is a cancer. So it's not. This is in a way we're doing active surveillance in this patient. So we have to think about resources in a big picture, quality of surgery, access to levothyroxine. Sometimes in some places you don't have it. So what is worse in this scenario? And we have to discuss with the patient. So it's feasible. So you just have to organize your service to do it and find people that can operate your follow-up and do it reliably.
Great, thank you very much. And Dr. Shah, there was a question about, in terms of access to surveillance, what about selecting on biology as opposed to extent of disease? Are we any closer to potentially selecting on biology and using molecular markers or anything like that to select for patients for active surveillance?
That's a great question. When we started the program here, I remember some 15 years back, we had several discussions between the surgeons, Mike Tuttle and Jim Fagan. And as you know very well, Jim is a guru's guru on BRAF. And there was a lot of strong discussion initially, but the interest was very minimal. You know, we didn't follow any of our patients with BRAF mutation. If they have done it outside, perfectly okay. But otherwise, I'm not convinced that the molecular mutations are more helpful than the clinical findings. Yes, in certain cases, they may be helpful, especially, you know, we see a small percentage of patients with BRAF and TERT. But those are very handful, and those are the ones probably much more irregular or angry looking tumors, or those with small tumors but nodal disease. So I don't think we are using it today, at least at Memorial, unless the patients had it done outside or it was sent for molecular testing, you know, the Afirma or the ThyroSeq, and they come back with BRAF.
Great, thanks. I see Dr. McIver has a question.
Yeah, I was just going to weigh in a little bit if I can, because I think this business of active surveillance, obviously we're doing a lot of this as well. I think most places in the US and many places around the world are already, you know, buying into this, that we don't need to operate, at least not initially, on a large number of these patients. But there is a health economics question that I have not seen really properly addressed yet. And that is, what is the cost of that surveillance over time? Because if you're talking about a 30-year-old woman with 55 years of life expectancy in front of her, and you're planning to ultrasound every year for the next 55 years, that has a cost that has to at least approach, if not exceed, the cost of doing the surgery. And so I think that we need to really understand the global costs of what we're doing. And in addition, start looking for other non-operative alternatives. For example, radiofrequency ablation as a potential alternative to that surgical approach for appropriate lesions. So I think there's a lot still to learn about how we should be managing these patients over the very long haul.
Great, thanks very much. So just in relation to the last case we discussed there, Dr. Shaha, when might you request calcitonin for a single suspicious nodule?
Something that looks bizarre. I don't like the thyroid nodule, or the pathologist tells me that there is something I'm not able to tell you what is going on. I would get a calcitonin. I've been pleasantly surprised now with the Afirma testing where they do the medullary marker. A small number are coming back as positive, probably the same number that the Europeans used to see. And one of the famous endocrinologists from Pisa, Aldo Pinchera, who was the founder of many of the guidelines in Italy, was a strong believer in doing routine calcitonin in every thyroid nodule. And that's why in the 2015 guidelines, that controversy was reopened. We don't do that routinely here because it is probably not cost effective. But as Brian mentioned, the cost of active surveillance for 65 years is so much. What is wrong in adding one calcitonin? I think it's a matter of choice. But I've been pleasantly surprised. Many of our patients are turning out to be calcitonin positive. The problem comes when you do the calcitonin and it is 13. Then you don't know where to go with that. 56, clear cut. 13, you can get that in CCL hyperplasia. You palpate the neck twice. You do it in the morning and in the evening, there is a difference. So you need to use it very carefully.
I think Dr. Freeman wanted to make a comment as well on this.
Just 2 comments on that. We've had a couple of patients from Europe who've had routine calcitonin, routine serum calcitonin with no imaging findings anywhere. So that sets up a whole can of worms with a whole cascade of investigations. Ultimately, we found that those patients had micromedullary in their thyroid. The second point I want to make is that with respect to fine needle aspirates, I always tell our trainees that of routine thyroid nodules, that if there are spindle cells reported in a fine needle aspirate, beware of medullary thyroid cancer. And it's at that point it should set off a cascade of investigations for medullary.
So I just want to comment, our practice is not to do calcitonin on every nodule by any stretch of the imagination. We selectively apply calcitonin when we have Bethesda 3 or 4. And the rationale for that is that 20% of our medullary cancers in a retrospective series were originally Bethesda 3 or 4. They went to surgery and they were medullary thyroid cancer. And that's actually a very common and well-recognized phenomenon. So before we had reliable molecular markers, we set up a process by which we would routinely do calcitonins on the indeterminate cytology. And we picked up a number of those medullary cancers as a consequence, not large numbers, but a few of them. Now that we're more routinely using the molecular markers, we're still doing the calcitonins. And I hope to publish later this year the performance of calcitonin versus molecular markers in detecting these medullary cancers in indeterminate pathology. They both work pretty well, but the calcitonin is a lot cheaper than the molecular marker. And so maybe that's something we could do before making a decision to send the molecular markers in indeterminate cytology.
As a sort of step on the protocol towards it, yeah. So there was another question, just maybe directed at Dr. Nixon. Just in terms of indications for completion, if you had a lobectomy with lymphatic invasion or minor extrafertile extension, does that ever push you to consider a completion, or what indications are you using for completion at the moment?
Yeah, so I think increasingly you can't make a decision about total versus hemi unless you have the size, as Brian brought in at the first case. So you're left with more nuanced things like, is there vascular invasion? What's the extent of vascular invasion? And certainly we would say if you have more than 4 foci of vascular invasion, there's historically been an association with poorer outcome. And so as a result, that in our hands is an indication for completion for radioactive iodine purposes. I don't think the literature on that is absolutely robust by any means, but that's one thing. And as we said earlier, extrathyroid extension in microscopic extrathyroid extension has been kind of downgraded as a risk factor. So it's less relevant, I think, at this stage, although I still find my multidisciplinary team, we're hesitant not to recommend completion in that setting.
Okay, well, Dr. McIver, do you want to wrap things up before the end of our session?
Yes, I appreciate that opportunity, Robbie. Thank you so much. And thank you for doing a really nice job in curating the questions today. It's great to work with you, and I look forward to working with you again in these things in the future. I really do want to thank Ian in particular for a stellar introduction to this session today, a really broad-based, erudite and insightful discussion about the advances that we've made in the management of patients with thyroid cancer over the last several years. And also addressing the questions and being part of our panel. Thank you very much, Ian, for all of that. Ashok, you are a master as always, and I really appreciate your involvement in this. Fernanda, a real pleasure to have you here all the way from Brazil, and I look forward to seeing you back on these panels in the future. And Jeremy, it goes without saying that you are always a pleasure to work with. So thanks to everybody. I hope the rest of the meeting goes as well as this first session did. Thank you very much.
Thank you.
Thanks, guys.
Well, thank you, Dr. McIver, for a wonderful session. And also, I'd like to extend my thanks to Dr. Woods. That was a marvelous session in which the pertinent questions relating to thyroid cancer were really very well addressed. We will now shift gears and go on to new technologies in diagnosis, imaging, and surgery. And there are 2 moderators to this session. It's Cesare Piazza from Brescia, Italy, and John de Almeida from Toronto, Canada. Since Cesare is the first speaker, I suppose John will start off in moderating this session. John, take it away, please.
Thank you, Dr. Leemans and Dr. Shaw. Really a tough session to follow up on. But it's really my pleasure to introduce the next session, which will be on new technologies in diagnosis, imaging, and surgery. And we really have a wonderful lineup of speakers this afternoon for you. And what we'll do is we'll get through each of the speakers and we'll reserve questions, which we'll moderate at the very end. I'm honored to moderate this session with Dr. Cesare Piazza. Dr. Piazza, many of you may already know, is a professor at the University of Brescia in Italy, and he's also the current president of the European Laryngologic Society. He has a number of achievements, including over 200 peer-reviewed publications, and he's a highly coveted speaker. What he's going to speak to us today about is the use of artificial intelligence in endoscopy. So we look forward to hearing more from you, Dr. Piazza.
Dear colleagues, good morning or good afternoon, according to the place of the world from which you are looking at this event. It's a great pleasure on my side to be part of it, and having been invited from the organization of Ifhnos Virtual World Tour to deliver you this lecture on our experience in the use of artificial intelligence in endoscopy of the upper aerodigestive tract. As you all know, the role of artificial intelligence in medicine has been greatly expanded in the last years, from embryo selection for in vitro fertilization to prediction of in-hospital death. And a number of other increasing areas of interest for this have been progressively introduced in the last years, among which, for sure, clinical endoscopy, of which I will talk to you today, as you all know, has specific drawbacks, mainly related to the subjective evaluation of its appearance, which is highly operator dependent and with a significant learning curve. To these drawbacks, some proposed solutions include the use of training with dedicated deep learning algorithms that can precise and objectivize measures that otherwise are left to the subjectivity of the operator. The type of algorithms that are usually applied in the field of deep learning and artificial intelligence are artificial neural networks, usually convolutional neural networks that resemble the structure of and the function of the neural tissues by a number of layers. The input and the output layers are always fixed, while the number of the hidden layers can be increasingly high, and to this we refer when we define the depth of a neural network. The field of which I'm working on in the application of artificial intelligence has been termed videomics in a review that we published together with the Stanford University some years ago. And the definition of videomics is for sure that a burgeoning field wherein several methods of computer vision and deep learning are systematically used to organize the unstructured data of video obtained during a diagnostic endoscopy of the upper aerodigestive tract, as well as of the GI or other part of the human body. For sure, in videomics, whatever the approach you use, the aim is to transform soft data like that obtainable from images, usually to be interpreted on a subjective way, into objective matrix, objective data, hard data, which can be measured, digitalized, and precisely quantified. Again, the objective of videomics can be broadly simplified, at least in these four tasks. The first, very basic one, is quality assessment of diagnostic evaluation to avoid, for example, blind spots. This has been already done, for example, in the GI tract, and is I would say, a sort of quality assessment of the work of the endoscopist. The other steps are in progress, and I would say the first two, identification, classification, and segmentation, are work in progress. And as I will show you in a moment, we are already there, at least for some aspect of the problem, while characterization is for sure the most ambitious bet of AI, and as I will tell you in a minute, is perhaps the near future. While classification is definitely something in the reach of the modern AI tools, and identification of the target, I would say, of the lesion to be evaluated also. Segmentation, it does the demarcation, superficial delineation of the margin of the lesion you are looking at, is something that is easily achieved in the larynx, for example, or oropharynx, less so in the oral cavity. One lesson learned as in the, I would say, human endoscopy is that the use of filtering of the white light by use, for example, of narrowband imaging is for sure a great help for the human eye as well as for the artificial intelligence, because it increased the level of contrast in between the lesion and the surrounding healthy tissue in a way that both the machine and the human eye are able to distinguish it with an higher accuracy, as you can see from this seminal paper published a few years ago by the group of the Stanford University. This preliminary experience from my group in the segmentation, I mean the peripheral delineation of the tumor, like every surgeon should do at the beginning of the resection or attempt of resection of an endoscopic lesion, is something that again can be significantly helped by use of filtered lights. And obviously it's something that can be done already now in, as I will show in a minute, in real time and therefore in the real life. As you can see, all the convolutional neural network used in this paper worked in a range of a few decades of milliseconds. So definitely a clinically usable time. Even though the difference between for example, different subsites and the proficiency of the algorithms in segmentating the lesion along different upper digestive tract sites was quite different, as I will show you in a moment. Other tricks that we learned that was for this kind of work, you need an incredible amount of data, an incredible amount of patients and videos with which you feed up your algorithms. And obviously, the larger the training set, the smaller the difference with the testing set. And obviously, the higher the numbers of the videos with which you feed your algorithm, the higher the accuracy of the segmentation, identification, and characterization that you will get about the observed lesion. In this subsequent paper, again, from my group of work, for example, we passed from a few decades of videos to some hundreds of them, again distributed heterogeneously among larynx, oral cavity, oropharynx, and hypopharynx, but still with these, I would say, rather limited numbers, we were able to segmentate correctly the lesions, as you can see in the pictures, and noticing that there were, I would say, notable differences in between the proficiency of these algorithms in the larynx, oropharynx, and hypopharynx, where always we got an intersection of a union value above 82%, while, for example, in the oral cavity, this accuracy was less optimal, below 70%, and this for a very clear reason that I will show you in with an example. This was one of our first semi-automated segmentation of glottic lesion, in which, as you can see, nearly in real time, the algorithm was able to correctly identify both under white light and MBI the target lesion within the correct box. This because the larynx has got a relatively easy and homogeneous epithelium with a fairly good and homogeneous illumination, both by rigid, flexible, white light or MBI endoscopies, and therefore the task of the machine are relatively easier, while for example, in the oral cavity, as you can see here, we are looking at right inferior gum of a patient already operated and radiated with a recurrence. You see that the machine is struggling to identify the correct box and the correct target in this complex anatomy. First of all, because there are at least 3 different epithelium, one of the cheek, which is different from that of the gum, which is still different from that of the tongue. And then because the illumination is not homogeneous, the field of the endoscope is not so easy like that of the glottic plane. And there are other confounding factors like different degree of keratinization of the epithelia, different degree of depth of infiltration of the lesions, some superficial dysplasia, some microinvasive other lesions. So the task for the machine is much more complicated, and the outcome so far is definitively inferior to that of an experienced human eye. Another field in which we are trying to get something out of the box of the artificial intelligence, which so far no human eye has been able to get out, is, for example, a precise quantification of concepts like normal vocal fold mobility, impaired or reduced vocal fold mobility, or fixed arytenoid or fixed vocal cord, which are the basis, as you all know for sure, of the T1, T2, T3 distinction in glottic cancer. So far, TNM system has been based on a very subjective element that indeed in the time of precision medicine can be not sufficient in order to get an accurate staging of these tumors. Using this open source computer vision tool published recently in the laryngoscope that was indeed thought for evaluation of unilateral vocal fold paralysis and changing it a little bit because the vocal fold cancer is not straight like in a palsy, but can be altered by the cancer itself. We modified a little bit the way of measuring the angular motion of the vocal folds through these 5 points or W-shaped frame that using mask RCNN, which is a convolutional neural networks frequently used for the human pose estimation and key point detection, we were able to get videos like this in which the W-shaped frame were followed during phonation and respiration in order to calculate the angular motion of this, I would say, T1A glottic cancer, in which the vocal fold mobility was perfectly normal, comparing it to other patients in which we would have defined the lesion at T2B, all the T2B glottic lesion with impaired vocal fold mobility, or even a T3 tumor for arytenoid fixation, comparing this preliminary data with the radiologic appearance, as you can see on your right, or even the surgical specimen in terms of infiltration of the vocal muscle and or structures like the cricoid joint. All these things are still preliminary, but our aim is obviously to quantify and objectivize in a very hard way the terms normal vocal fold mobility, hypomotility, and fixation, and to correlate these data with the other coming from radiomics and pathomics in order to get the full picture. So in conclusion, so far, artificial intelligence is still beyond the possibility of the human eye in some field like tumor detection, tumor delineation or segmentation, and I would say also in the overall evaluation of the complexity of some areas like, for example, the oral cavity. But this is what we obtained in a few years of work, and for sure the increasing interest on the whole planet, I would say, about this element, a new integration of machine with human work will for sure open us in the future interesting avenue of integration of data and the guidance of our treatment on the base of even more precise medicine and surgery. And last but not least, I would like to remember to all of you the 14th Congress of the European Laryngological Society that will be held in 1 year from now in Milan, and where I will wait all of you presenting your data and your experience in laryngology. Thanks for your attention. Okay. So if we can go on with the panel, it's my honor to introduce the next speaker, which is Professor Stefan Lang, Chair of the Department of Otorhinolaryngology and Head and Neck Surgery at the University Hospital in Essen, Germany. His field of expertise is in tumor immunology and advanced tumor surgery, and is investigating the role of robotics, virtual reality, 4K 3D imaging, and artificial intelligence for head and neck surgery. His research interests are additionally focused on the analysis of tumor-host interaction, tumor escape mechanisms, and tumor microenvironment. And in fact, today we will talk about tumor microenvironment. Please, Stefan, stage is yours. Stefan, we cannot hear you. Please turn on the microphone.
It's good now. Can you hear me now?
Yeah, we can hear
Yes.
you.
That's perfect. Thanks.
Sorry for that. You see my presentation?
Your slides aren't showing just yet. If you go to
Okay.
share screen and hit the up button, you should be able to show your slides.
Okay. I just did it already. I will do it again.
I think you have to share your screen first, then go to your presentation.
Now it's working?
Perfect. Good.
Okay. Sorry for the inconvenience. Again, thank you so much, Cesare, for the kind introduction, and a warm welcome to all my colleagues from Germany. My special thanks go to the organizers for creating such an excellent event. Since many years, we are analyzing the tumor microenvironment. And today I want to show you how we can translate basic science into clinical applications. and I especially emphasize on new technologies in diagnosis, imaging, and surgery. And as you all know, T cells play a major role in the tumor microenvironment, and also the polymorph mononuclear myeloid-derived suppressor cells. These are suppressive neutrophils. And we could demonstrate in head and neck cancer that high levels of granzyme B T cells in conjunction with low levels of C suppressive neutrophils have a very good survival. And we also wanted to know what's going on in the circulation. So we performed a proliferation assay, and in co-cultures of T cells and suppressive neutrophils, we could demonstrate a decrease of T cell proliferation. And this shows you a short video of this spatial interaction of neutrophils and tumors, as you can see here. And this is the mixed area. This is enriched in neutrophils and in T cells. And the green area, these are neutrophils only, and the red area, these are enriched in T cells. And it's even more important to have a closer look at the tumor draining lymph nodes. Why? I can show you here in patients having no neck metastasis. High levels of neutrophils in the tumor draining lymph nodes are associated with a good prognosis because these neutrophils can present tumor antigens by MHC class 1 and MHC class 2. It's completely the other way around in patients yielding low levels of neutrophils. However, if you just evaluate patients with positive lymph nodes, metastatic lymph nodes, then you see it's completely vice versa, because now these neutrophils act protumorally, and high levels of neutrophils do have a poor prognosis. And it's even more important to have a closer look at the so-called pre-metastatic niche. Remember, these are lymph nodes in a positive neck which are tumor draining but metastasis free. And even in these patients, you see the pro-tumoral active lymph nodes or neutrophils in this setting. Bad prognosis, T cell suppression. And we also could show that there was an upregulation of the programmed cell death ligand 1, which is responsible for the observed effects, because here you can see in these tumor draining lymph nodes in tumor-bearing human patients, we could see an upregulation of PD-L1. And the same holds true in mouse experiment. After injecting tumor cells in the flank of these mice, you see an upregulation of PD-L1 on these neutrophils. And using blocking antibodies against PD-L1, we have been able in co-cultures of T cells and neutrophils to restore the previously suppressed proliferation of T cells. And the special emphasis of my talk is diagnosis, and the intravitreal 2-photon microscopy is a new and innovative method of in vivo monitoring cell migration in real time. And we did this also on tumor draining lymph nodes in a mouse model, again, injecting tumor cells into the flank and analyzing the neutrophil and T cell interaction as well as migration. And this video shows you the migration of the green labeled T cells and the red neutrophils, how they do interact with each other. And in the pre-metastatic niche, which means, remember, tumor draining metastatic free lymph nodes, we could show more neutrophils on the one hand, but less T cell neutrophil interactions. And T cells are a very important player. And this are data out of a collaboration with Professor Ferris from the University of Pittsburgh Cancer Institute. And a research fellow, Benjamin Kanzi, could show that PD-1 high expressing cytotoxic T cells are associated with a poor survival. And on the other hand, PD-1 low expressing T cells do yield a very good survival. And in a mouse experiment, he could demonstrate that checkpoint inhibition by nivolumab followed by irradiation is reducing these immunosuppressive PD-1 high TILs on the one hand, but rescuing the PD-1 low TILs on the other hand. And these TILs, they are immunoprotective, and maybe they could serve also as a biomarker. So let's go and further characterize cytotoxic T cells by single RNA sequencing. And this allows us to do a multidimensional analysis of tumor heterogeneity. And this is a UMAP analysis of 18 carcinoma patients of the tumor. And you can see you're going to end up with different cell types. Let's have a closer look at the cytotoxic T cells. Well, every single dot resembles a T cell. And you see the different colors. Green are the naive cells. Orange are the cytotoxic, the fully effective cells. But then the tumor kicks in and is binding via PD-L1 to PD-1 on the surface of the T cell. And by doing so, it renders the T cell first pre-dysfunctional and finally exhausted. So there are different steps of, let's say, maturation during this process. And if you do have a closer look at this area, pre-dysfunctional and exhausted cells, the majority of these cells is PD-1 positive. And by checkpoint inhibition, maybe we are able to antagonize the suppression, which means revert pre-dysfunctional cells back into functional PD-1 low cells, but not doing it by adjuvant checkpoint, but instead of neoadjuvant checkpoint inhibition. Why? Well, we all know that adjuvant checkpoint inhibition is only successful in 15 to 20% of the patients. But neoadjuvant blocking means we have a higher load of tumor-specific antigens in the tumor microenvironment, which can lead to an increased expansion of tumor-specific T cells, not only the tumor, also in the lymph nodes and circulation. It's a non-treated patient, so we have less therapeutic resistant tumor cells. And of course, we all know that our patients just yield a good access for especially translational approaches. And the first presentation was given by Opaluri 2017 at the ASCO meeting, followed by this paper where he gave pembrolizumab as PD-1 checkpoint inhibition neoadjuvant setting. 36 patients, 8 patients have been high risk, which means positive margin or extracapsular spread. And he did just did quantify the pathologic treatment response via tumor cells, necrosis, current debris, giant cells. And he could show an equal distribution of pathologic treatment response. 50% of the low-risk group did respond and 50% nearly at the high-risk group. But what I have to point out is the one-year recurrence in the high-risk patients was 16.7%, which is lower than the historical rate of 35%. And a downstaging was seen in 90% of the patients. And our data, together with the literature, prompted us to do a neoadjuvant trial using a PD-L1 inhibitor, atezolizumab, because it blocks the inducer and not the responder. And we are part of the IMCOR network provided by Hoffmann and Roche. So it's neoadjuvant before we do the surgery. It's a phase 2 study, single arm, and we do include every resectable head and neck carcinoma. And this is the study design. First, we take the biopsy on day 0. This is followed by the infusion of the checkpoint inhibitor. We are monitoring the circulation on day 1, 8, and 15. And finally, 3 or 4 weeks later, we are going to resect the tumor. We also do a microbiome analysis. Of course, we want to check for safety and feasibility, for the immunological consequences, and we will correlate the tumor infiltrating and the circulating immune cells, with special emphasis on the tumor lymph nodes also. And maybe we are able to establish a predictive biomarker just to monitor the treatment effects. So these are our 6 patients, which we could include right now. We've seen 11 adverse events, 9 minor events, pruritus fever, for example, one pulmonary embolism which was not related to our study drug, and one decrease of platelets. But I want to highlight on these 5 patients yielding positive lymph nodes, because in these patients we could see a regression of lymph nodes in 3 patients. And this is our hallmark patient. It's a oropharynx carcinoma yielding a positive lymph node in the neck, as seen by this CT scan. And after 1 dose of rituximab, the metastasis was completely gone, not only on the CT scan, but also on the histopathology workup, which is very impressive. So let's conclude. It's worth not only to analyze the primary tumor, as I showed you, but also the lymph node metastasis, because in early cancer patients, there are 2 important players, T cells and neutrophils. And the neutrophils in a high level are associated with an improved prognosis because they can act antitumorally. But on the other hand, this is a so-called dichotomy of neutrophils. In a positive neck, they are going to act protumorally, especially, as I told you, in the pre-metastatic niche, which means tumor draining metastasis-free lymph nodes. And the topic of the session just emphasize on imaging. And I could show you that intravital 2-photon microscopy is a very innovative method to learn about the interaction of immune cells, in this case T cells and neutrophils. And together with our mouse data and human data, we could show that the upregulation of PD-L1 is responsible for the suppression of T cells. And diagnosis means single-cell RNA sequencing is at the top notch of innovative research, because by doing so, we could also show that pre-dysfunctional and exhausted T cells are accounting for poor prognosis and immunosuppression. And by using neoadjuvant checkpoint inhibition, we are able, and we can maybe able, revert these pre-dysfunctional cells and render them functional. And this is a very important addendum to the modal therapeutic approach, including surgery. This was my talk. I thank all of you for your attention. I thank all my co-workers, the institutes for funding real research, and of course, Bob Ferris for the long-lasting friendship, as well as contribution collaboration. Thank you so much.
Thank you, Professor Stefan Lange, for your wonderful presentation. In the interest of time, all the questions will be at the end of the session and will be managed by John de Almeida. So it's now my pleasure to introduce Dr. Luke Morris, a physician scientist specialized in head and neck surgery, associate member in surgery at Memorial Sloan Kettering Cancer Center, and associate professor of otolaryngology at the Weill Cornell Medical College. He set up a cancer genomics laboratory focused on head and neck cancer immunogenomics. He holds multiple leadership positions in cancer research and clinical care, and have been principal investigator for numerous studies. Today, he will talk us about genomics and biomarkers. Please, Dr. Morris.
Grazie mille. Thanks, everybody. Hi from New York. I hope you can see my screen okay. Stop me if you can't. So that was 2 wonderful talks, and this will, I think, follow nicely Professor Lang's talk about the tumor microenvironment and immunotherapy. My lab studies cancer genomics and the interaction between the genome and the immune system. I'll mention that we have intellectual property licensed to PGDX owned by my hospital, and those are that's my only disclosure. So we use the word precision oncology a lot, and you'll hear this term used quite a bit. One of the questions or statements that I want to really question in this talk is this one. Is it in fact reasonable to say that precision genomic technologies are revolutionizing cancer care? And in fact, here are 3 specific statements that I'm going to ask you if you believe, before and after this talk. Number one, is it fair to say that precision oncology is revolutionizing how we triage patients with advanced head and neck cancer to different therapies? Is it fair to say that immunotherapy is a game changer for head and neck squamous cell carcinoma? And can we say that tumor mutational burden and other measures of neoantigens in cancer that we can measure as clinicians are key determinants of a tumor's response to immunotherapy? So let's start with this first statement. Does this first statement really hold up? Well, when we use the term precision oncology, what we generally mean is some sort of strategy to match the right patient to the right drug at the right time in their cancer treatment. And I think this is an important and a wonderful goal. Winston Churchill said, however beautiful the strategy, you should occasionally look at the results. And this is, I think, the perfect encapsulation of a lot of concepts that are subject to hype in medicine. In fact, I've been hyping this particular quotation from Churchill for quite some time, and it was only recently that I realized that he never actually said this. Someone made it up and attributed it to him because it just seems so Churchillian, but I think the statement has some value. So is there any evidence that a precision oncology approach for our patients with cancer is actually effective? There's actually only been one randomized controlled trial randomizing patients to either standard therapy or some sort of genomically targeted therapy based on a molecular test. This trial, the Shiva trial, was negative. And another one has never been done. Now, that was all the way back in 2015, and you could say, well, that was old technology. We're doing better now. And so the Moscato trial from Gustave Roussy was published in 2017. A number of patients with metastatic cancers had molecular profiling or genomic profiling done. 19% of them were matched to some sort of genomically targeted therapy. And you can see here that the response rate was a modest 11%. More recently, there was a US-based trial and an international trial, again, using next-generation sequencing to identify targetable alterations in tumors, and then enrolling patients in these trials. And overall, even if we can increase that percentage of patients who are matched to therapies, the response rate is still that same number. It's about 11% of patients enrolled in the trial who achieve a tumor response. The National Cancer Institute in the United States did a similar large-scale study looking at a number of targets. And in the first report of the 3 most promising targets, basket studies, patients with a number of different cancer types, you can see in the right-hand column that objective response rate was quite low, 0, 4, and 8% for these 3 targets. So we have to look at this critically, and I'm fortunate to work at a hospital where we do a lot of clinical tumor sequencing as part of standard clinical care. And so as of a few days ago, this is what the dashboard for tumor sequencing looks like at Memorial Sloan Kettering. Our hospital has sequenced 89,000 samples as part of clinical care. These are mostly stage 4 cancers across 67,000 patients. And we've learned a lot. We are good at taking small volumes of tumor material and finding alterations. But how many of these alterations are actionable? And by actionable, I mean, is there a drug with some evidence of clinical activity in some type of cancer? Level 1, 2, or 3, depending on how closely that activity matches the type of cancer you're interested in. And if we look at the tumors of the head and neck, which I've outlined here with red arrows, in thyroid cancer, we have a lot of actionable mutations. That blue column there, those are BRAF, right? So we have BRAF mutations in thyroid cancer that are potentially targetable. But in salivary cancer and in head and neck cancer, that number is much lower. Probably the ceiling at the moment is 25% of tumors have a potentially actionable alteration. We've dived a little deeper into what these alterations look like, and in a publication in 2016, recently updated, we think that about 21% of squamous and salivary cancers have targetable genomic alterations identifiable with DNA sequencing. Of those patients, about half of them manage to have their treatment guided by the alteration, meaning there's a drug available on a trial the patient can be enrolled on. And of those 10% of patients, about a third of them, not bad, about a third of them had a tumor response. And in the end, what this means is that of the tumors that get sequenced, in the end, at most, 3% of patients are potentially benefiting. I don't know that a response equals clinical benefit, but at most 3% of patients with head and neck cancer undergoing tumor sequencing potentially have a clinical benefit. So this is a low number, right? This is not the number that we want. It shows that we have this gap here. We are good at finding genetic alterations in tumors. We have therapies for some common alterations, but we still really have a long way to go here in bridging this gap. Even if we achieve a response, we know that with genomically targeted therapies that these responses can be short-lived. A key reason for this is the clonal heterogeneity of cancer. Cancers are not homogeneous masses. They are heterogeneously comprised of different subclones with different molecular profiles. And ultimately, those tumors that have the highest intratumoral heterogeneity, right here, are most poised to undergo adaptation or evolution under the pressure of therapy and for resistant subclones to outgrow and lead to recurrence. And so this is the fundamental obstacle we face with targeted therapy. It's evolution. It's the ability of genetically heterogeneous tumors to evolve under selective pressure. And so for many cancers, and particularly for head and neck cancer, we have low numbers of actionable mutations right now. Few of our patients are able to be matched with therapy, and we have high rates of resistance to therapy. Even if we achieve response, it is not durable. What are we going to do about this? Well, are there any cancer treatments that can evolve, that have more diversity, more plasticity, and better memory? If you were listening to Professor Long's talk, you know the answer here. The cancer is the immune system. The immune system is this incredibly diverse anti-cancer treatment. The number of T cell receptors we have in our blood, 10 to the 18, is equivalent to the number of grains of sand on the planet. So we all have this incredibly effective, diverse, and adaptable anti-cancer therapy that we're born with, the immune system. And perhaps the solution is to make the immune system work better when cancers escape its surveillance. Certainly, just in the last 10 years, we've seen that genomically targeted therapies, the bottom line, the number of patients in the United States who are eligible for and responding to genomically targeted therapies has been growing very slowly, and it's a low number. And just in the last 10 years, checkpoint inhibitors, immunotherapy, the number of patients with cancer who are eligible for these drugs and to achieve a tumor response to these drugs has dramatically increased and outpaced these molecular targeted therapies. So would you say then that immunotherapy is a game changer for head and neck cancer based on the data that you just saw in the prior talk? Would it be fair to say, as the Guardian newspaper in London said in 2016, referring to nivolumab, that immunotherapy is a game changer? Well, I always get a little worried when I see the word game changer because that seems like a little bit of hype. And in fact, 6 months later, the same newspaper used the same word to describe the fact that this game-changing drug had been rejected by the British National Health Service as not cost-effective. Let's go into why. We know the data from the nivolumab study, the pivotal study of nivolumab on the top, the pivotal study of pembrolizumab, both anti-PD-1 therapies on the bottom. Absolutely better than standard therapy. Absolutely the greatest improvement in systemic therapy in head and neck cancer in decades. And yet, at 1 to 2 years out, the majority of patients do not respond, do not achieve clinical benefit. Now, based on that survival benefit, clinically, there is now great interest in moving anti-PD-1 up to the first line. And in the United States, anti-PD-1 therapy has been approved by the FDA for use in the first line for patients with metastatic head and neck cancer. Why? This was based on the KEYNOTE-48 study, a study of pembrolizumab, where patients were randomized to either first get chemo, and then if they progressed, to move on to potentially another therapy such as anti-PD-1, or to start with Pembro. And if they started with Pembro, their overall survival was better. Thus concluding, QED went the conclusion, starting with Pembro is better than saving it for later. That is the conclusion that was made and that has been accepted in the US system. Is this fair to say? Was the Keynote 48 study truly a comparison of giving Pembro now versus giving Pembro later? Well, the patients in this study were randomized to either get Pembro upfront or to start with chemo. And presumably, if you were in a country where anti-PD-1 was approved, you could then move on at progression to get anti-PD-1 later. But here's the thing, this study was not solely run in countries where there is access to anti-PD-1 therapy at progression, okay? And so we would think that at progression, these patients would move on to standard of care, anti-PD-1. In fact, because this study was run on an international basis, many of the patients were treated outside of the US and outside of Western Europe. Only 25% of patients at progression went on to get anti-PD-1, okay? And so that is a key trick that is used if you want to make your drug look better, is you randomize patients internationally so that some patients don't have access to anti-PD-1 in their health system at progression. And so this study, which claims to be a comparison of anti-PD-1 first line versus anti-PD-1 after progression on chemo, is not really that. It's a comparison of Pembro now versus Pembro never. And in that respect, the evidence that it's good to give anti-PD-1 in the first line setting, which has been accepted in our country, is probably very weak. The bottom line here is that we have extracted all of the benefit that we can from anti-PD-1 monotherapy. The majority of our patients do not benefit, and in patients who do not benefit, it is as good as giving them nothing. And therefore, we need more precision in how we deploy these therapies while we're developing better therapies. So we're left with these two kind of, I hope not too disappointing conclusions, which is that for these clinical genomic studies that we're doing, they're not as useful as we had hoped. We need more actionable findings. And immunotherapy in head and neck cancer, not as useful as we had hoped. We need to predict responders better. And so the great hope in the field that I work in, which is immunogenomics, is could these two enterprises help one another? Could genomics provide a way to have more precision in how we deploy immunotherapy? And could immunotherapy help us make all that genomic data actionable? Well, I'm referring to a concept that you may be familiar with, known as tumor mutational burden. This is one theory for how genomic information about a tumor could help us understand which tumors are going to respond better to immunotherapy and which are not going to respond well to immunotherapy. And so in this diagram, what I'm showing you is the theory known as the neoantigen hypothesis, that if you have a mutation in DNA that results in a mutated protein, that mutated protein can then be processed by a cell, a tumor cell or an antigen presenting cell, or really any nucleated cell that has MHC, which we call HLA in humans. If that neopeptide that comes from the mutated protein can be presented on MHC class 1, it can then be seen by the immune system, by a T cell. So in other words, mutations can generate non-self signals that are recognized by the immune system called neoantigens. And the more mutations you have, the more potential neoantigens or tumor rejection antigens, foreign signals to the immune system a tumor has. And you would therefore theorize that the more mutations a tumor has, the more likely it is to respond to immunotherapy. This was shown early on with data in melanoma and lung cancer, but is this applicable across all cancers? Is this applicable in head and neck cancer? This number, TMB, or tumor mutational burden, is simply the number of mutations in the tumor per megabase of DNA. Okay, so the tumor exome has 30 megabases. So if you have 100 mutations in a tumor, your TMB might be around 3. We did a pan-cancer study of 1,600 patients treated at Memorial Sloan Kettering a few years ago, looking at this simple question: does that number TMB predict survival after immunotherapy across all sorts of different cancer types? Looking at these patients, we found that in general, overall cancers, yes, it does. So if you're a tumor with a TMB in the top 10% for that cancer type, survival was much better than tumors in the lower percentiles of TMB. The higher the TMB goes, the better overall survival goes. This is the hazard of death. So survival is better as TMB goes up. This is true directionally in most types of cancer. And here's head and neck cancer here, borderline statistically significant. The thing that I want to point out, though, is that the cutoff for high TMB is different across different cancers. A high TMB for one cancer may be a low TMB for another cancer in terms of predicting response to immunotherapy. Across all tumors, yes, in general, we have a higher response rate at higher levels of TMB. But on the right, I'm showing you an ROC curve. And a really good predictive biomarker would have an ROC curve that has an area under the curve that's very high, a curve that looks something like this. And you can see that the predictive value of TMB across all cancers is really quite modest, not very impressive. Well, let's go to head and neck cancer specifically. Here are the ROC curves for how the commonly used biomarkers perform. TMB, not particularly good, the blue line. CPS score, or IHC for PD-L1, actually quite a reasonable biomarker, and T-cell infiltration. So what we've done is we've taken exome data from 130 head and neck cancers. This is work that's still in progress. And what we find is that there are 6 molecular subtypes of head and neck cancer relevant to immunotherapy response based on these genetic factors that you can get from a next-gen sequencing platform that we use in clinical care in the United States. And looking at these subtypes, we see that these 2 subtypes are the worst. This is an immunogram where different features are plotted on a radar plot. And the further out the curve is, like in subtype 4, probably the best outcome here. In subtype 4, you can see that we have high scores for most of these features. These patients do better. And the patients who do the worst are in subtype 1 and 2. They have very little T-cell infiltration. They have low CPS, low TMB. They tend to be virus negative. They tend to be smokers, and they tend to lack an APOX signature. So this is work in progress that I'll describe more at a future time. In the end, these are the biomarkers that we are currently examining in head and neck cancer. But there's still quite a bit of work to be done. We're really just scratching the surface. So TMB, is it a key determinant of immunotherapy response? For some cancers, yes. Overall, modestly. For head and neck cancer, very weak. In the end, when we're thinking about these statements, I want to end with this statement from Richard Feynman, the Nobel Prize winning physicist. It doesn't matter how beautiful your theory is. It doesn't matter how smart you are. If it doesn't agree with experiment, it's wrong. So much of what we do in biomedicine is plausible. It's exciting scientifically. But in the end, if it doesn't agree with experiment, which for human beings with cancer is a randomized control trial, if it doesn't agree with experiment, it's wrong. So that's all I've got. I just want to thank the members of my lab who do the analysis and the wet lab research, understand cancer and the immune system better. And I appreciate you all joining. Thank you.
Thank you, Dr. Luke, for the fantastic presentation. I appreciate it a lot. And we will pass now the stage to the next speaker, Dr. Fares Bemilou, which works at the European Hospital in Marseille, France. He has an exclusive practice of endocrine surgery and is one of the pioneers of the autofluorescence imaging of parathyroid glands in thyroid surgery. His approach of autofluorescence combined with Indocyanine green fluorescence perfusion during total thyroidectomy already demonstrated a significant impact on preservation of parathyroid glands postoperative function. In line with this concept, today we will talk about his experience on parathyroid localization. Please, Dr. Bemilou.
Hello, can you hear me?
Yes.
Can you see the presentation?
Still no. Oh, no, I see you, but you have to share your screen and then click on the presentation.
So my screen. Is that okay?
Perfect. Now press the, okay, perfect now. Good.
Thank you very much for inviting me to talk about fluorescence techniques in thyroid surgery and parathyroid fluorescence technique in parathyroid surgery. And since the subject is large, we will focus on the imaging fluorescence techniques, and we will focus the field on just the thyroid surgery. And actually, there are two kinds of intraoperative fluorescence technique that we are currently using in routine. The autofluorescence, which is the fact, as we will see, that the parathyroids emit a spontaneous fluorescence signal, and the use of a dye, the indocyanine green, in order to assess the perfusion of the parathyroid glands after surgery, and to visualize also the parathyroid gland vessels performing angiographies intraoperatively. So autofluorescence is a technique, is a phenomenon, a physical phenomenon that has been described for the parathyroids in 2011 in the Vanderbilt University in the United States. And as we said, it is the fact that when this parathyroids are submitted to laser near-infrared light excitement, they emit a natural signal, and this allows to detect them by spectroscopy in real time, but also by the imaging systems. And there were the first papers on the subject were published on 2016 with different devices, lab built or commercially available systems. Here is an example of how it works. You just use a camera which shows you, after a little dissection, the parathyroids, which are brighter than the surrounding tissues. So it's very simple, it's immediate, and it helps identifying, as we will see, the parathyroids better than what the eye can see. So the first studies showed initially with different systems that the reliability of the images were excellent. And we also know from the different initial studies that sometimes the parathyroid glands are identified by the systems before the naked eye. And as you can see on the table, there are a great discrepancy between the different figures. And this is related to the fact that there are different ways to use the systems. Of course, if the system is used and the autofluorescence identification is performed very early in the procedure, well, the rates of parathyroid glands identified before the naked eye would be higher than if it is used for confirmation only after the lobectomy. This reliability and the diagnostic accuracy of the different systems was recently assessed by a meta-analysis which showed a very excellent results of sensitivity, specificity, negative predictive and positive predictive values, and the area under the curve of the RAC curve was excellent. And they also showed in this meta-analysis a better diagnostic accuracy with probe-based than with image-based detection. In routine, we are not so convinced on the specificity figures that has been shown in this meta-analysis, but maybe it is because of the heterogeneity of the way to use the system. Because in routine, there are several false positive issues. And here are some examples. Here is a thyroid. Here you can see the parathyroid, and it is here true positive, and in the thyroid area, there is a nodule, a colloid nodule that is much brighter than the image shown by the parathyroid, and this is a classical false positive image. And there are also extra thyroid positive image. Here is the parathyroid, and as you can see in the central neck compartment, you will see lots of fluorescent images, which makes very difficult the interpretation of such images. So there is a need for a study that assesses exactly the false positives. But there are now studies that show with the use of artificial intelligence to detect the patterns of the parathyroid glands as opposed to the false positive images. So what we know also from the clinical impact of this new technique is that it improves autotransplantation and also inadvertent resection. But as you can see, the number of studies on which this meta-analysis is based is very few. And when you use another study, another meta-analysis on the same subject with less studies, well, we see a different, statistically different improvement of patient outcome, transient hypocalcemia, and even nearly different improvement in permanent hypocalcemia for the people who use the autofluorescence as opposed to the people who are operated on by conventional thyroidectomy. But in another meta-analysis, using just one more study, the difference is no longer significant in the hypocalcemia for the rates of postoperative permanent hypocalcemia. So a lot of things, a lot of data has to, we need a lot more data to be possible to interpret. And the possible interpretation for the positive effects of this technology is that, well, the fact that we had an increased perception of the parathyroids during a dedicated procedure, which requires to stop operating for a while, look for the parathyroid, and focus the attention on specific areas instead of vague attention on the whole field. And this helps us plan the operative surgical strategy and perform the best possible dissection. But as we said, we need more data, and we need to improve the quality and the comparability of the studies by standardizing the definitions and the practical uses of the fluorescence imaging. And we also need multi-center or registry studies, including low-risk and high-risk parathyroid centers, since the majority of the currently existing studies are performed in high-volume centers. So, and here are some currently recruiting trials, so we'll have many more data soon. The second way to use the fluorescence is first to assess the parathyroid gland perfusion at the end of operation. We use the indocyanine green, which we call the ICG, at the end of surgery intravenously, and it predicts the need for a treatment initiation. See, when you have, as you can see in the image on the right, well perfused white parathyroid at the end of operation, usually it has been shown that you need only one well perfused parathyroid to be able to avoid treating patients. It may also help us adapt to the extent of surgery when we have two badly perfused parathyroids at the end of a lobectomy, you can use either to stop your surgery or to be more conservative on the thyroid on the second lobe. But you have to remember that there's a small, very tiny, but existing risk of anaphylaxis. So we have to weigh the need for this technique. So the other way to use the fluorescence and the ICG is trying to avoid the devascularization of the parathyroid glands by using the ICG as an angiography. And here is an example. Here you see the two parathyroids. It's the left lobe. Here is the inferior and the superior parathyroid glands. And as you can see, this image is very nice, and it shows exactly the way to dissect. And this is generally superficial, so you can generally manage to keep this vascularization performing an extracapsular dissection. So we have performed this. There are Nielsen data on the subject, and but in practice, what does it? How does it help us? Here is Graves' disease with a large lobe. At this stage, we don't see clearly the inferior parathyroid. And when we look at it with the fluorescent, the autofluorescence, here it is. Here it is, and here is the superior parathyroid. And when we inject, here's what we see. We see exactly the vessel getting into the parathyroid. And when we compare that to the reality, and after dissection, here is the parathyroid, and here you see the vessel. And knowing that early, before starting the dissection, we can manage to perform the best possible extracapsular addition. Yeah, at the end of surgery. Okay. And the second interest is that it can help us improve our knowledge on parathyroid vascular anatomy, and in order to be to learn more and to be able to teach the students and the trainees, and maybe using the artificial intelligence one day to be able to build prediction tools according to the localization of the parathyroid around the thyroid. So here is an example in practice of how we combine autofluorescence and ICG. Here is a small lobe. It's the second lobe of a total thyroidectomy for cancer. What we used to do for years before is to look for the nerve first. Here it is. Here is what we think is its path in direction to the larynx. So this is what probably would have been our plan of dissection. Now, if you with the autofluorescence, here is the parathyroid, and here it is now. It's more obvious, and at this stage, it help us wonder and try to assess which one of these potential all these vessels is the vessel feeding the parathyroid. And when we inject, so here is what we see at first after a few seconds, and a few seconds later it is more obvious, and with an image processing it's even more obvious. And when we compare that to the real image, here is the parathyroid, and here in green it seems to be the path for the pedicle, where after dissection it is more obvious. So now we can know exactly the plan of dissection in order to keep this very tiny pedicle intact. So Autofluorescence helps identify healthy parathyroid better and earlier than what the eye can see. It is clearly interesting in thyroid surgery, where we know systematic exploration is recommended and frequent and severe complication can occur. And we are talking about the postoperative hypoparathyroidism. The ICG allows us to predict the correct parathyroid function postoperatively, and we can combine autofluorescence and ICG, and hopefully one day artificial intelligence, in order to help us improve our way to dissect and ultimately, hopefully, the patient outcomes. Thank you very much for your attention.
Thanks to you, Fares. It was wonderful. I greatly appreciate it, and I will have for sure some questions to address to you later. So it's my pleasure now to present the last speaker, Dr. Joseph Dayan, Associate Professor of Plastic and Reconstructive Surgery at Memorial Sloan Kettering Cancer Center. He was honored to be the 2021 Godina Fellow by the American Society for Reconstructive Microsurgery. His main focus of interest are related to management of lymphedema, microsurgical breast, and head and neck reconstruction. Dr. Dayan is the co-director of the Lymphatic Surgery and Research Program at Memorial Sloan Kettering and director of the Facial Nerve Program. He's an internationally recognized expert in this field, and herein he will deliver a lecture on fascial reanimation. Please, Dr. Dayan.
Thank you so much for that wonderful introduction. It's really a pleasure to be here, and I'm just going to pop my screen up. Special thanks to Dr. Shah and Dr. Shah. But my interest and my practice at Memorial is really focused on facial reanimation and head and neck reconstruction, my disclosures. And when I first started, first of all, I owe a lot of credit to Fu Chen Wei, who directed my fellowship, David Zhuang, and Julia Terzis. These people have had a massive impact on me. But when I went into practice and saw the specific problems in specific patients, there were a couple preconceived notions or things that I was taught that just didn't always work so well. Oftentimes, I didn't see so many of these patients. I was told they had poor prognosis, and that's why I wasn't seeing them. But the truth is that because of advances that you have made in head and neck cancer, these patients are living actually longer than they ever had. On the reconstructive side, there's really no consensus on strategy. Many of the patients I've seen did not receive facial reanimation at the time of the tumor ablation. Some patients do, but with varying techniques. And part of the problem is that they're just, every case is different. And practice patterns and availability of somebody who's specializing in facial nerve is different. And these patients have different resections. So some resections are distal, some resections are proximal. So you get these different patterns of facial nerve defects. And then is there a microscopic disease in distal nerve branches or in the proximal trunk that could have an effect on your result? And then finally, radiation. And the patient's age is also a variable. There were very little data on these variables, but a lot of strong feelings. So I'm just going to present to you our experience in our patient population. The other issue is volume. You can see in this gentleman, after a paroidectomy and neck dissection, which is mainly what I'm discussing, and radiation, there's a lot of volume loss. The ear can get stuck to the ramus of the mandible. You can get a skeletonized appearance, not to mention the neck issues, pain and contracture. So how do you deal with all this, not just the nerve, but these secondary issues? Following that was synkinesis. I used to just hook up nerve branches, multiple cable grafts, like many people do. And it's just unavoidable to some degree of synkinesis, which can be very problematic. I was also sort of brought up to look at patients in their 70s and higher as maybe being best served with just keeping it simple, do a static sling. But static procedures, although you can get a decent result at rest, in motion, in real life, usually have a horrible quality of life. And this patient has unopposed pull to the normal side, and so she's biting on her lip. She does not have intelligible speech over the phone, and she's not happy. Other options out there are temporalis transfers, very effective, and the main benefit giving you an immediate smile, at least in theory, right after you get off the table. The downside is that these do absolutely nothing for blink, and blink and eye closures should really be a priority. It is pure torture. You can lead to vision loss, and is the main problem for the patient, not just the smile. So the approach or basic principle I'm presenting is to use all available sources of electricity for dynamic reanimation of the whole face and target them to specific targets to minimize synkinesis. But to do this and to resurrect the patient's own muscle, time is precious. So that means basically after 2 years, results from trying to get those native muscles to work are going to rapidly deteriorate. And so you're probably going to need to replace muscle after 2 years. So we try to do these patients at the time of ablation, at the time of their parotidectomy. But if we can't get to them at that time, we want to get that to them certainly, usually within the first year. And these patients don't generally want multiple operations. Time for them may be limited on the planet. So the question becomes, what single operation could you give this patient with the highest reliability and for the best quality of life? You're not necessarily going to hit a home run, but what would give you, what if this was my face, what would I have somebody do if I knew maybe I only have 3 to 5 years on the planet? And so these are the sources of electricity we have to work with generally. Obviously, the facial nerve is always number one. It's the only source of spontaneous motion. So if we can graft it, we will graft it. But usually that's not enough. Nerve to masseter is another source of electricity and has become very popular in the last 5 years. And then finally, mini hypoglossal transfers. There are other transfers such as spinal accessory nerve, deep temporal, but these are the top 3 ones we use. They all have different attributes. The facial nerve is spontaneous and gives you the best result, but you can get synkinesis, and there's variable reliability as that nerve graft gets longer and longer. Then you have nerve to masseter, which grows like a weed. It will almost always work, but it's on or off. There's no basal tone, and the patient needs rehab. So your results are directly correlated to how much rehab they're working with. Otherwise, it doesn't really give you much of a result. And then finally, mini hypoglossal, which does give you basal tone, but it is not as volitional. Finally, all of these cases I'm presenting with every nerve reconstruction will always throw on an adipofascial anterolateral thigh free flap. The reason for this is twofold. One, it gives very vascularized tissue over those facial nerve reconstructions and nerve grafts. And number 2, it restores the contour of the face, and it may mitigate effects of radiation, particularly contracture and pain in the neck, although that's a subject for further study. I'm going to go through with very limited defects to the most maximal defects. And for a straight up short segment defect of the facial nerve, the answer is very easy, just a cable graft. This is an example of a woman, young woman who incidentally was found to have oncocytic parotid tumor, was going to need radiation. And so I took her, I was consulted after the operation. I took her right back the next day in order to stimulate those distal nerve branches and identify them. Her blink was completely out. Did a sural nerve graft, and then did. In her case is skip flap, so she can hide the scar in the underwear line. 2 little cable grafts, a flap, and she also had an endoscopic brow lift. She did have brow paralysis, but this is her result. She does not need an eyelid weight. And this is a very sort of reliable, straightforward thing most of us have done here. Here is a T4N1 M0 adenoid cystic carcinoma invading the masseter and temporalis muscles. Here's a straightforward defect, nerve grafts, and an ALT flap. And this gentleman did not have revision. That bulk went away with radiation and time. And he did not need a eyelid weight or revision. He did have a spinal met and did succumb to his disease approximately 3 years later. But you can see on spontaneous motion is satisfactory. And again, this is a gentleman with a EB associated malignancy, a simple nerve graft, and this one nerve graft did wonders. MSAP flap and cervical facial flap, and here's his result following radiation. And his lifespan was, I think, 7 years. Now, what about complete facial nerve sacrifice? This is where nerve grafts can have variable results. There's more synkinesis and more variability. So the whole idea is to still do the nerve graft, but not rely totally on it. You're going to supplement with nerve transfers. And so in this case, this was nerve grafts from the trunk to smile and eye closure, but then we did a nerve to masseter for smile and a mini hypoglossal for lower facial motion. These are targeted to distal branches, so I'm not hooking up the entire facial nerve to minimize synkinesis. And then we cover with an adipofascial flap. This is a T2N2BM1 parotid cancer with LVI in this gentleman. And you're looking at his result at 8 months post-op. All these patients were radiated. And he ended up having metastatic disease. But you can see his quality of life as he reported it to us. Back then, he traveled internationally. He was able to help people, which he dedicated his life to. Another T4N0 adjuvant radiotherapy. This was actually a recurrence. So you're seeing nerve grafting and nerve to masseter and an adipofascial ALT. We take those nerve grafts from a minor motor branch to nerve to vastus lateralis because the thigh gives us not only the adipofascial flap, but it also gives us a nerve donor. And there is preclinical evidence to suggest motor nerve grafts are superior to sensory nerve grafts. And this you can see her on communicating spontaneously. A gentleman, we've all seen this, somebody with a delayed diagnosis of parotid tumors presenting with facial paralysis. He'd been paralyzed for 1 year, but that's plenty of time to resurrect his native muscles. I would not just do a nerve graft for smile. I want to get his eye, I want to get his blink back. I don't want him to have a paralyzed eye for the rest of his life. So the idea is we're going to do a nerve to masseter transfer for eye because that'll reinnervate his eye within 3 months, and a nerve graft for smile and everything else. And of course, an ALT free flap. He was radiated postoperatively. Now this is nerve to masseter, so he has no spontaneous blink, but when he can close his eye, engaging his nerve to masseter, as you can see. The ALT flap restored his contour. He doesn't look like he was radiated. He doesn't need eye drops. His eye is not paralyzed, but he does close his eye when he eats. So you have to discuss some of these things with the patient, but overall he has a much better quality of life than the static procedure. And then what do you do when there's no proximal stump available? The stump is just intraosseous, not available. And this is just a nerve to masseter to the upper division and mini hypoglossal to the lower division. And this is one of those cases to see what that actually looks like. He had complete left facial paralysis, and this is him animating. In these cases, they need a lot of rehab, and the more they practice, the better they'll look. What about older patients? I was always told not to do dynamic. This gentleman was 83 years old. He has an infected tumor, and he's going to have complete facial paralysis. Static sling, I would not put in an infected field. So all I did was nerve to masseter. And of course, we had to do a big ALT flap on top of this. And even at 4 months, you can see him with some nerve to masseter function. And at 2 years post-op, you know, he has a decent smile and actually up into the lower eyelid. So his quality of life is better than static sling. This is a patient, not a head and neck patient, but metastatic melanoma to the brain, complete right facial paralysis for 16 months, and just showing you what dual nerve transfers can do, nerve to masseter, mini hypoglossal, and this is her result at 1 year. She's still doing well and left her support group. She now goes out in public, eats at a public restaurant with friends, which she was never doing before. What do you do when the muscle is not available? So this patient had 17 surgeries, morphiiform basal cell carcinoma. Now with another recurrence, was radiated twice preoperatively and going to require proton beam postoperatively with this through and through dissection, really devastating situation for her. In this case, we're going to bring muscle into the field, mini latissimus and a chimeric Tdap, but I don't want to get into too much in the details. But basically, we're bringing in muscle innervated by the facial nerve. And this is her result following proton beam radiation. And you can see her just speaking spontaneously with a satisfactory result. In conclusion, prioritizing blink is important. Age is not a contraindication based on our observation at all. Radiation is also not a contraindication. And focus on selective and targeted reinnervation and consider a flap for soft tissue replacement. Thank you so much.
Thank you for some wonderful lectures, Dr. Dan and all the previous speakers. Great topics. And maybe what we'll do over the next 10 minutes or so is take some questions. Before we go to questions from the audience, I'd like to ask a question of Drs. Long and Dr. Morris about the use of immunotherapy in the definitive treatment setting. I think we've all been quite excited about what we've seen with the keynote studies and the checkmate studies with Dr. Ferris, Dr. Burtness, and Dr. Cohen. In the definitive setting, the findings have not been equally exciting. There was a recent study for patients treated with radiation and chemo, adding immunotherapy, the Javelin study, and the results were not favorable. We saw the results of Dr. Upaluri's study using neoadjuvant immunotherapy prior to surgery. In that study, there were 0 complete pathologic responses. So the question for Dr. Long and Dr. Morris, how do we select patients in the definitive setting for patients who may benefit from immunotherapy? And are we being a little bit, have we sort of started a little too early on that trend of incorporating IO in the definitive treatment setting?
If I may start first, thank you so much, John. And I guess this is a very important question. Selecting a biomarker for predicting patients' response or for selecting patients is of utmost importance. And up to now, there are different ideas, and I did highlight some of these possible biomarkers, for example, PD-L1, another one could be granzyme B, and there are also some biomarkers related to neutrophils, but we do not know yet, and this is a major problem. And the same was also true for the adjuvant setting, as you know, but in total, the response in the neoadjuvant setting has been more promising than in the adjuvant setting. And so this is a push to go ahead, but you're completely right. We do not know so much about the appropriate predictive biomarkers yet. Yes, that's true.
Yeah, not much to add. I think that was well articulated by Professor Long. The additional piece of the puzzle that we're working out clinically is what are we combining neoadjuvant immunotherapy with? There are a number of interesting biological hypotheses as to why radiation or other techniques that ablate the tumor draining lymph nodes decrease the effectiveness of neoadjuvant immunotherapy. And that is a hypothesis that has been put forward as to why the Javelin study, for example, was not did not show any benefit. With studies that combine chemo with immunotherapy, pathologic CR, pathologic complete response rates are remarkably high. And we've seen this in a study here, and others are beginning to report the same thing. And so I think some of the attention clinically is shifting away from combinations with RT to combinations with chemotherapy as a means of maximizing response in the neoadjuvant setting, and then following up perhaps with surgery or other definitive treatments.
Thank you both. I'm going to take some questions from the audience. So Deepa Nair from Mumbai asked a question to Dr. Piazza, which hopefully we'll get Dr. Piazza to answer. There was some, obviously you pointed out that in the oral cavity, these AI-mediated endoscopies don't function as well as in the larynx. And in particular, in patients who have field change or pre-malignant change, how can we use these technologies in the oral cavity when you have sort of more field effect?
Well, this is for sure one of the most ambitious area in which we will use, hopefully, AI in the future, which is the in-depth characterization of an observed lesion in the oral cavity as well as elsewhere, and which is by far the most difficult task we can ask to something like that, because neither our eye, human eye, the most powerful or expert human eye can be successful so far to get 100% accuracy in detecting the real nature of an oral premalignant disease or even a frankly malignant disease in terms of depth of invasion, nature of dysplasia, and so on. So we are working on that. We got already good outcomes adding the MBI to the white light in this task, and perhaps we will get even better outcome adding on the top of MBI the AI as described before. But honestly, we are I would say some years behind this kind of achievement, and so far we are working in improving the segmentation, which is far easier than characterization of the lesion. And even in this, the machine algorithms are still, as I demonstrated, not proficient enough in comparison to the human eye. So the direction is definitely that, but we have to work a lot about that.
There was a question from Dr. Cernea asking about other relevant neoadjuvant trials in oral cavity cancer, and Dr. Long kindly included a reference there for everybody, so please look at that reference. I'd also add another reference by Dr. Upaluri, Ravi Upaluri and his group published in Frontiers in Oncology on neoadjuvant therapy. So for all the participants, please look at those two papers. Dr. Nair also had a question about, and maybe this is a question for all of our panelists, but probably in particular Drs. Long and Dr. Morris. Do we think that head and neck surgeons may become irrelevant in the future? I was at the recent ASCO meeting, and there was a New England Journal paper published in rectal cancer where about a handful of patients, I think just over a dozen patients, were treated with IO single agent and no surgery, no radiation, with all complete responses. So the question from Dr. Nair, are we as surgeons going to become irrelevant in the era of IO and systemic therapies?
not during the next, let's say, I would say 2 decades, and even not in the future, because as we all know, the best survival rates are depending on a multimodal approach. And multimodal means surgery is a basic principle of this treatment setting, followed by, right now, as routinely applied, radiation and maybe chemotherapy. So these 3 treatment columns are tested, they are established, and there's no doubt about it that it's working. And the surgeon plays the major role because he is going to decide, is this patient resectable, is this tumor resectable or not? So this is my first argument for surgery. And the second one is, surgery is the major part, and there will be addendums, additions of therapy. Let's say after resection, the patient is taking a neoadjuvant inhibitor for the rest of his life, or doing something else in a neoadjuvant setting. But from my point of view, and I have to say this as a surgeon, surgery will still stay as major treatment column.
Thank you. Maybe if I could ask a question of Dr. Ben-Lou, very exciting sort of imaging studies for parathyroid and identification of it. How can we be sure your imaging modalities are not false positives? And maybe you're looking at it with a fluorescence methodology and you think it's devascularized, but maybe it's not. Are we falsely explanting paras and reimplanting them based on these imaging studies? And how can we gauge the accuracy of autofluorescence for parathyroid viability?
Well, thank you for your question. Actually, the false positive occur with the autofluorescence imaging, which, by the way, do not give any information about the vascularization of the parathyroid. If you want to know if the parathyroid is vascularized or not, you have to inject the dye, because autofluorescence does not depend on the vascularity of the parathyroid. And it is different from the signal is different from the other the false positive images, since it is often very easy to find to see the difference, because there is a quite specific pattern of fluorescence for the parathyroids. But you have there's a short learning curve to make the difference, but it's quite easy, and sometimes it is not. And in that case, we just realize that the technique is not, we don't use the technique, we use only the classical way to identify the parathyroid, which is the gold standard, the surgeon's assessment.
Thank you very much, Dr. Ben-Lou. And finally, for Dr. Dayan, one of the things two things we grapple with when we do facial nerve reconstruction at the University Health Network in Toronto is, as you pointed out, older patients. That's one, and I'd love to see some data on the older patients and reconstruction. And the second patient is where you have a long segment, maybe from the second genu all the way out to some peripheral branches. And the question for Dr. Dayan is, do you have a cutoff of when you would graft when you have a proximal stump in terms of length of the defect?
Thank you. Those are great points. I mean, with regard to the last question first, if the field was previously radiated and it's a very long defect, like 10 centimeter defect, I just would not trust that nerve graft. I would start thinking about even a vascularized nerve graft, which you can easily harvest. Basically, the pedicle of the anterolateral thigh flap is there's an artery, a vein, and a nerve that just run all together. I honestly would say that would be a very rare case, Personally, I would still nerve graft it if it's technically possible, but I just wouldn't trust it, and I would rely more on nerve to masseter, mini hypoglossal transfers, or whatever nerve transfers would work, best in your hands. For me, it would be nerve to masseter to the upper division and mini hypoglossal to the lower division. But I think if there's any way you can get some spontaneous motion, I would just caution that if you're transferring, grafting a nerve trunk, there's a ton of power. If it wasn't such a large defect, and you can get hyperkinesis, hypertonicity, and a very tight face if you're channeling, a fire hose into a little distal nerve branch. And I think those are the variability in nerves is hard. With regards to older patients, I just wanted to ask you what specific data would you want?
No, it would be great. I have a senior colleague who says whenever we're doing a nerve graft in an 80-year-old patient, that's not going to work. Just have there been any publications that support sort of the fact that 80-plus-year-old patients do actually have successful reinnervation?
I just showed you one who was 83, actually 84 by the, he was a late 83 and a half, 3/4. But you could see clearly that he had reinnervation present at 4 months post-transfer, and he had no less of a result than any of the other cases I showed earlier on. In terms of large series of patients over the age of 80, I just don't see them. So there's not going to be like a series of like 50 patients where there's going to be high level data. I can only tell you that I've not observed in the cases we've done, and we're currently preparing manuscript of our experience with oncologic patients. So we'll have all the data on ages, but I didn't show it in this talk, but I also have a 78-year-old woman who we did nerve to masseter, nerve grafts, and she's one of my best results, personally one of my best results. And there's a variability in facial nerve that I can't, that's beyond, I think, technique and patient variables that I don't think we've been able to figure out yet. There are some technologies out there that will hopefully, I know we're going to be one of the sites working on this. Neuraptive. It's basically antifreeze, marinating the little nerves in antifreeze at the time of cutting the nerve. It basically halts supposedly Wallerian degeneration. There's very good preclinical data and very convincing, animal data for it, but I haven't seen it with my own eyes in a human. I don't know if it works, where it's going to be blinded and randomized. So that's probably going to be a couple of years before that comes out.
Great, thank you. And I think we have time for maybe one last question from the audience. It's Dr. Nair from Mumbai. Would you routinely do an EMG or nerve conduction velocity study before secondary reanimation? And I think that's for you, Dr. Nair.
Yeah, definitely. I would always do needle EMG if the patient is presenting, at the time of surgery, I'm not doing one, but any patient presenting for delayed reconstruction, even if they're just 6 months out, just to get an objective baseline. It's even much more practical for somebody who's maybe a year and a half or 2 out, and you really don't know, should I just replace the muscle or should I try to reinnervate their native muscle? It becomes very important. But I always get a baseline and then a post-op at 1 year.
Great. So I think that brings our session to a close. I'd really like to thank all the speakers for some wonderful talks and insights onto various areas in diagnostics, imaging, and surgery. A wonderful lineup, and thank you also for a great session, and to Dr. Shah and the meeting organizers, Dr. Chaturvedi, wonderful session.
Thanks, John. It was a pleasure to moderate this session with you, and I congratulate all the speakers of this session and the previous one. And it was a great success on my side. Thank you very much.
Well, thank you, everybody. I would like to take a moment and echo what you just heard. It was really an amazing morning or afternoon, depending on where you are. I feel that even though the two sessions dealt with different areas, there are themes that emerged if you listen to both of them. And these themes include a radical change, really, in the way we look at our specialty and our diseases. So in the morning session, it became clear that once incurable diseases, unresectable diseases, you heard the discussion about anaplastic thyroid cancer, and the innovations in both immuno and targeted therapy have really changed that notion. And in the second session, the innovation in the areas of artificial intelligence, visualization, reconstruction, and targeted and immunotherapy beyond the thyroid gland has also added a significant area of progress in our specialty. And I was listening to these talks and I was thinking about the last virtual tour and the ones before, and how far we have come. I mean, the lectures that typically used to be surgery, radiation, and chemo, and here's how we treat these diseases, of course, continue to be the foundation of our thought process. But today we've heard really cutting edge, world-class presentation of very innovative ways of dealing with our patients and the challenges that we face every day. So thank you, everybody, for outstanding presentations. Thank you for the participants and attendees for being so engaged and your questions. And then I, of course, want to take a moment and again acknowledge the vision and the incredible leadership of Dr. Jatin Shah, who put this whole organization into motion. And it's because of that leadership and vision that we can be here today exchanging cutting edge ideas across the globe, even in the absence of an in-person meeting. So with that, I'd like to close the session. Wish everybody a great rest of the weekend, wherever you are. It is really hot in Houston, so I'm going to probably be heading to the water. I know Renee Lehman's, my co-chair, will do the same. He texted me that he's going to the beach. So everybody enjoy the rest of your weekend, and thank you very much. And with this session is closed.